Welcome to the November 6th through 7th, 2024 board meeting. My name is Sang-Oh, President of the board. Before we convene, I would like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allot 2 minutes to each individual providing comments, as we are expecting significant comments anticipated today and to ensure everyone has an opportunity to comment. We'll begin with public comments for individuals attending in person in sunny San Diego, followed by public comments by individuals participating via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I'd like to ask the staff moderating the meeting to provide general instructions. Moderator.
At the time that we call for public comment, people will be asked to raise their hands to participate in public comment online. You can do that by tapping the hand button at the bottom of your screen. For our mobile device users, you may need to hit the ellipses button, that's the ... and cycle through 3 different pages in order to find your hand. And for our dial-in users, you may need to dial *3, or in fact, you will need to dial *3 in order to raise your hand. We have a Q&A box in the lower right-hand corner of the screen. If you wish to type a question, please reserve that for technical support. If you need to make a comment, you can type the word comment into the box, and I will put you in the queue for your turn to speak. If you are having trouble with your microphone, we'll try and resolve that and let other people speak ahead of you. And those are the instructions. Back to you, President O.
Thank you, David. I'd like to take a roll call to establish a quorum. Jesse Crowley.
Licensee member present.
Morning, Jesse. Trevor Chandler. I don't believe Trevor is joining. Renee Barker.
Licensee member present.
Thank you, Renee. Indira Cameron Banks. I don't believe Indira is joining today. Jeff Hughes.
Public member present.
Thank you, Jeff. KK Jha.
Licensee member present.
Thanks, KK.
Did that work?
Jay Newell.
Public member present.
Thank you, Jay. Satinder Sandhu.
Licensee member present.
Thank you, Satinder. Maria Serpa.
Licensee member present.
Thank you, Maria. The microphone's a little. Nicole Tebow.
Licensee member present, and no other person 18 years or older is present with me at this time.
Thank you, Nicole. And Jason Wise. I don't believe Jason's attending today. And I'm here. A quorum has been established. I truly appreciate everyone's time and commitment to the board and California consumers. We have a very full meeting today and tomorrow. I ask everyone participating today to be respectful of the work before the board today. We encourage participation by members of the public throughout our meetings at appropriate times. The board respectfully requests that when comments are provided, they're done so in a professional manner, consistent with how the board conducts its business. Before we move to the next agenda item, I would like to also remind board members participating via WebEx to please remain visible on camera throughout the open portion of today's meeting. Members, if you need temporarily to turn off your camera due to challenges with internet connectivity, please remember to announce the reason for your non-appearance when you turn off your camera. Next agenda item 2, public comments for items not on the agenda. We will now accept public comment for items not on the agenda. Again, not on the agenda. You're not required to identify yourself, but may do so. I would like to remind everyone that the board cannot take action on these items except to decide whether to place an item on a future agenda. Accordingly, if your comment pertains to an item on today's or tomorrow's agenda, please save your comment for the public comment period specific to that agendized item. Members, following review of the public comments for this agenda item, I will ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the board and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. We'll begin with public comment in San Diego. Seeing nobody coming up here, we're ready for WebEx.
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of your screen. For our dial-in users, dial *3 to raise your hand. And for our mobile device users, you may need to hit the ellipses button, the ... and cycle through one of 3 pages in order to find your hand. We're going to start with Julie Threet. Hold on just a moment. We're going to send you a request to unmute your microphone. You'll be given 2 minutes to speak, and I'll give you a 30-second warning before your time expires.
Julie Threet. I'm a healthcare worker in Butte County, California, and I am here to implore you to please stop the COVID-19 vaccine. I am vaccine injured by 2 shots of Moderna, and I was injured with microangiopathy and 2 detached retinas. My mother was murdered in Santa Clara County by 4 shots. I've got several resources for you to go look at and do your research. React19.org, AmericansForHealthFreedom.org, MilitaryAccountability.net, VAERSAware.com, and the Medical Doctors for COVID Ethics International. You are the Consumer Protection Agency. And now that we've got President Trump and RFK Jr. in office, it's not going to be long before this entire mRNA platform is up for discussion and will be taken down. Please, I'm imploring you. When I came before you a year ago on November 9th, there were 74 dead people in VAERS by a vaccine that was administered at your pharmacy in California. I came back to you in December, there were 77. I came back to you in April, there was 81. I came before you in July, there was 83. And as of today, in VAERS, you have 87 dead Californians from a vaccine administered at one of your pharmacies. You need to get an agenda item on a future meeting, bring in the honest doctors, the honest researchers,
30
and make
seconds.
sure that you're fair to the consumers and protect them in this state. Thank you for your time today.
Thank you for the comments.
Next, we're going to hear from Richard Dang. Hold on just a moment. We're sending you a request to unmute your microphone.
On behalf of the California Pharmacists Association, I just wanted to provide a comment for consideration for a future agenda item regarding licensure examinations and residency programs in California. In response to public comments that were heard at the most recent licensing committee meeting a few weeks ago, CPHA issued a survey to residency programs across the state to get a better idea for the issues that are facing our postgraduate trainees. We have shared the results of the survey with Anne to the board a few days ago, but I want to just review some of the findings that we found. We heard from 61 residency programs over the span of 2 days. That was a really fast response and a really swift response from our residency programs across the states. Of the programs that we heard that 50% of the respondents did have a termination date for residents who were not licensed within 120 days of the start of the residency program, which was October 28th. And that is in line with the ASHP accreditation standards. The standards do allow for some flexibility, and the rest of the programs have a deadline in December or January. But the most stark data is that as of this year, there were 57% of residency programs who had 1 or more residents at risk of dismissal because of their licensure examination status. There's some other stark data, and that is an increase from the previous year as well. Up to 82 residents
30
are
seconds.
at risk of dismissal for this year because of their licensure examination. There are a variety of solutions that were discussed in the survey, but this is a growing trend and an issue that is facing us in the state. And we ask that the board add this to a future agenda item for further consideration and discussion. Thank you.
Thank you for the comments, Dr. Dang.
Next, we're going to hear from John Gray. Hold on just a moment. We're going to send you a request to unmute your microphone. You may need to dial *6 in order to unmute.
Hi, good morning. This is John Gray, registered pharmacist with Kaiser Permanente. We just want to echo the comments that Dr. Dang just made. We have a couple of observations related to pharmacist examination for licensure. one kind of anecdotal observations of declining pass rates on licensure exams, particularly the CPJE, and two, the ASHP residency accreditation requirement that residents are licensed within 120 days of their start date, or complete at least 2/3 of their residency as a licensed pharmacist, is sometimes at tension with the CPJE examination schedules. And so we have a couple of recommendations for the board to consider when it considers whether it wants to agendize a discussion about this, which we would encourage. One would be studying the factors that might contribute to declining pass rates on licensure exams among pharmacy license applicants. And two would be assessing whether there are opportunities to schedule the CPJE to better accommodate meeting ASHP's 120-day licensure requirement. Thanks very much for the opportunity to comment.
Thank you for the comments, Dr. Gray.
And those are all of our comments via WebEx.
Thank you, David. All right, members. Any thoughts, questions?
President O, this is the
Yes,
moderator.
David.
We do have a last-minute request via WebEx
Sure.
for public
Okay.
comment. All right, Jackie Stover, hold on just a moment. We're going to send you a request to unmute your microphone.
Raised. I'm not sure how that happens, but my name is Jackie Stover and I am a specialty pharmacist. I would just like to request that at the next Sunset Report discussion in 2025, to include section 4071.1 of the Business and Professions Code, specifically section F as it relates to remote processing. Thank you, and we appreciate the Board of Pharmacy's time and efforts.
Give it a comment.
And we have more still. Inez Anton, hold on just a moment. We're going to send you a request to unmute your microphone.
Hi, my name is Inez Anton. I'm a California licensed pharmacist working for a specialty pharmacy. And I actually want to second Jackie Stover comment and want to thank the board for their continued efforts to include section 4071.1 of the Business and the Professions Code, especially section F as it relates to remote processing. We are aware that will be discussed in the next Sunset Report, and we are asking if there is anything that we can do from our side to expedite the process. Again, thank you for the Board of Pharmacy, and we really appreciate the time, the efforts on working on this matter. Thank you.
Thanks for the comment.
And what appears to be our last one from the letter C. Hold on just a moment, C. We're going to send you a request to unmute your microphone. All right, C,
Hello
we're going
there.
to
My
send
name. Yes, thank you. Hi, my name is Cindy, and I just want.
Go ahead, please. Sorry.
Oh yes, my name is Cindy, and I just want to support both previous speakers regarding sections 407.1 of the Business Professional Code, and would like to have this included in the next Sunset Report discussion. Thank you.
Thank you for the comments.
And that appears to be our last one for comments not on the
Thank
agenda.
you, David. Okay, members, any comments? And Nicole, please just unmute and speak. I will try to keep an eye out for your raised hand, but sometimes I get distracted. So, all right. Okay.
Just wanted to note, I believe we already discussed this at the licensing committee meeting, but I believe we already are discussing the CPGE exam, correct? That for a future date, or was that something that Anne was working? Do we remember?
Yeah, at the staff level, we're looking at a few things and reaching out to some impacted people. Happy to report back to the chair of the committee and then make a decision.
Perfect. Thank you.
Thank you, Jesse. Any other member comments? All right, it's hard to see everyone. It's like it's gotta be like exercising all day today. All right, next agenda item is 3, recognition and celebration of pharmacists licensed in California for 40 years. The board's recognition of pharmacists licensed in California for over 40 years is posted on our website, and pharmacists are provided with a certificate when they reach this significant milestone. Do we have any pharmacists present in person today for the board to recognize? Anyone in WebEx? David?
We are open for public comment via WebEx on agenda item 3. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. For our dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request via WebEx, do you wish to continue with the agenda?
Yes, please. Thank you, David. Again, congratulations to everyone who has been licensed as a pharmacist for over 40 years. The board truly thanks you for your contributions to public health. Next, agenda item 4, approval of board meeting minutes, including the meeting materials or draft minutes from several meetings, beginning with July 31st through August 1st, 2024 meetings. I welcome your comments, members, on the draft minutes, and I will also entertain a motion to approve the July 31st through August 1st, 2024 minutes. Members?
Mr. President, I have a correction on the July 31st to August 1st minutes.
Yes, Dr. Serpa.
And it's on page 3, the last part of section 2 says Dr. Serpa indicated interest in learning more about the use of samples by advanced practice pharmacists, including the historical and current use. And my comment was just of samples, so I would remove the words by advanced practice pharmacists. It was to be more inclusive.
Okay. You know, Maria, I'm going to put you on the spot. With that, would you be willing to maybe making a motion to approve?
Certainly, I'm happy to move that we approve the minutes from the board meeting, the draft board meeting minutes from July 31st to August 1st, 2004.
Thank you, Maria. Any second?
I'll second.
Thank you, Satinder. With a motion and second, we're ready for public comment. Any other in San Diego? Ready for public comment in WebEx?
We are open for public comment via WebEx. If you'd like to make a comment on this agenda item and the motion, please raise your hand by tapping that hand button at the bottom of your screen. Dial-in users, dial *3 to raise your hand. And for our mobile device users, you may need to hit the ellipses button. That's the ... in order to find your hand. People will be given 2 minutes to speak, and this time I'm only going to give a 10-second warning. Our first request comes from Preeti. Hold on just a moment. We're sending you a request to unmute your microphone. All right, Preeti, we're going to send you a second request to unmute your microphone. I see that you're on a mobile device. You may need to cycle through your 3 different pages, hitting the ellipses button in order to accept the request to unmute. I see you've unmuted. Are you with us?
Yes, I am. Can you hear me?
Yes, go ahead, please.
Okay. Hi, my name is Preeti. I'm a California licensed pharmacist working for a specialty pharmacy. And as my other colleagues has commented, I just want to support them. I just
Hi,
joined.
Preeti. So sorry. I'm sorry to interrupt. It is in the, I think you might wanted to speak on the previous agenda item. I'm just trying to
Yes,
make
yeah,
sure
I just,
everybody stay consistent. So just letting you know, this agenda item is just for public comments for
okay.
the approval of the board minutes. I'm
Okay, I'm so
sorry.
sorry. Thank you.
No
I
worries.
joined the
Thank you
late.
for the comments.
Thank you. Bye.
All right, David, go ahead.
That is our only request at the moment.
Thank you, David. All right, with a motion, a second, and public comment, we're ready for a vote. Jesse, how do you vote?
Abstain.
Thank you, Jesse. Trevor is not here. Renee?
Approved.
Thank you, Renee. Indira is not here. Jeff?
Yes.
Thank you, KK.
Yes.
Thank you, Jay.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, Nicole.
Yes.
Thank you. Jason is not here, and I vote yes, the motion passes. Next, moving to the draft minutes from the September 12th, 2024 board meeting. I welcome your comments on the draft minutes. Also, I will entertain a motion to approve the minutes. Members?
Hey, Sung, this is Jesse. I move to approve the draft minutes.
Thank you, Jesse. Any seconds?
This is Nicole. I'll second.
Thank you, Nicole. With a motion a second, let's go to public comment in San Diego. Seeing none, ready for public comment in WebEx.
We are open for public comment on 4B and the motion. If you'd like to make a comment on this motion, please raise a hand by tapping the hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment on 4B as in Bravo. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. Thank you, David. With a motion and second and public comment, ready for a vote. Jesse, how do you vote?
Yes.
Thank you, Jesse. Renee?
Yes.
Thank you, Renee. Jeff?
Yes.
Thank you, Jeff. KK?
Yes.
Thank you, KK. Jay?
Yes.
Thank you, Jay. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. And Nicole?
Yes.
Thank you, Nicole. And I vote yes, the motion passes. The final draft minutes for our consideration are from the August 23rd, 2024 Disciplinary Petition Committee meeting. Members, I welcome your comments on the draft minutes and will also entertain a motion to approve the minutes. Members?
I'll move to approve the minutes for.
Thank you, Jesse.
Yeah, thank you.
Seconds? Thanks, Renee.
I'll second.
Renee seconds. All right. With a motion and second, we're ready for public comment in Sacramento. Seeing none, we're ready for public. San Diego. Thank you. Just forget that I'm in San Diego. Feels so weird. In San Diego, not in San Diego, ready for WebEx.
We are open for public comment via WebEx on the motion for 4C as in Charlie. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand. We will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. Thanks, David. With a motion and second and public comment, ready for vote. Jesse, how do you vote?
Yes.
Thanks, Jesse. Renee?
Yes.
Thank you, Renee. Jeff?
Yes.
Thank you, Jeff. KK?
Yes.
Thank you, KKJ.
Yes.
Thank you, Jay. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. Nicole?
Yes.
Thank you, Nicole. And I vote yes, the motion passes. All right, next agenda item 5, discussion and consideration of waiver related to temporary provisions for compounding certain parenteral drug products consistent with provisions of Business and Professions Code Section 4062. As included in the meeting materials, Business and Professions Code Section 4062 provides authority for the board to waive application of any provisions of pharmacy law or its regulations during a declared federal, state, or local emergencies under specified conditions. The board, through an adopted policy, has delegated authority to the board president to issue a waiver for up to 30 days. Consistent with this authority and in response to the public health emergency stemming from consequences of Hurricanes Helene and Milton, I issued a waiver on October 16, 2024 to support the temporary provisions for compounding certain parenteral drug products following the issuance of federal guidance. As it is anticipated, there will be long-term impacts This item was placed on the agenda for the board to consider if an extension of the waiver is appropriate. Members, I believe an extension is appropriate. I note that the meeting materials offer a potential motion. As I open up for member comments, I would also entertain a motion if you believe such action is appropriate. Members, your comments, thoughts?
I'd like to make a motion.
Oh, thank you, Renee. Any second?
Second.
Thank.
For purposes.
Do I need to read it? Yeah. Okay, yeah. Okay. Okay, so the motion, consistent with the board's authority in Business and Professions Code Section 4062B and the Declaration of Public Health Emergencies by Health and Human Services Secretary Becerra, the board extends its current waiver, temporary provisions for compounding certain parenteral drug products through January 31st, 2025, or until the end of the declared emergency, whichever is sooner.
Thank you, Renee. Jay, second.
Second.
Thank you. Maria, you have comment? Go
You
ahead.
have discussion for board discussion. One is in the materials, it said that the board has received 3 requests for waiver and 2 did not comply with the provisions of the FDA guidance. I'm curious as to what the 2 that did not meet the standard, what was the issue, if that's something that should be publicly understood so that we don't have additional waivers that don't qualify, if that's something that could be shared, or if not, that's okay too.
So I'll speak in general terms if that's okay. The provisions under the FDA guidance are limited to specific types of products. And there were requests received that went beyond those included in the federal requirements.
Okay, great. So then individuals should review the federal guidance in applying for the waiver. They should. The other comment was just to add to the public record is the FDA has also released information that extends expiration date on certain IV products. It's posted on their website that there's that some IV products are good for 6 months beyond the posted expiration date on the product, and encourage everyone to be familiar with that.
Appreciate that comments, Maria. Any member comments before we go for public comments? Seeing none, ready for public comment in San Diego. Seeing none, ready for public comment in WebEx.
We are open for public comment via WebEx for agenda item 5 and the motion before us. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. As a reminder to our mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand. For our dial-in users, please dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. Thanks, David. With a motion and second and public comment, ready for a vote. Jesse?
Yes.
Thank you, Jesse. Renee?
Yes.
Thank you, Renee. Jeff?
Yes.
Thank you, Jeff. KK?
Yes.
Thank you, KK. Jay?
Yes.
Thank you, Jay. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. Nicole?
Yes.
Thank you, Nicole. And I vote yes. Motion passes. Next agenda, item 6, report by the California Department of Consumer Affairs. I'd like to welcome Melissa Gear, Deputy Director of Board and Bureau Relations with the Department of Consumer Affairs, to provide an update from the department. Ms. Gear, the floor is yours.
Can you hear me now? Perfect. Thank you. Thank you, President O. Hello and good morning, President O, Vice President Crowley, Executive Officer Sodergren, and members of the board. I'm Melissa Gear, Deputy Director of Board and Bureau Relations, and I appreciate the opportunity to share the Department of Consumer Affairs update with you this morning. So first, I will start with a DEI update. DCA's Diversity, Equity, and Inclusion Steering Committee met last month, and we are excited to announce its newly elected leadership. Reggie Varghese, Medical Board of California's Executive Director, will serve as chair, and Marlon McManus, the Board of Behavioral Sciences Assistant Executive Officer, will serve as vice chair. With Reggie and Marlon's years of experience and sincere commitment, we greatly look forward to accomplishing many DEI initiatives under their leadership. Next, we have an update on the new unconscious bias training for board members. I am also excited to share that DCA is updating its current Unveiling Unconscious Bias training to specifically focus on board members, your critical roles, and how unconscious bias can affect your decision-making authority. The training will be self-paced and available in DCA's online learning management system, or LMS. We anticipate launching this new training in early 2025, and board members will be required to take it annually. Hold on just a second. We had a minor technical glitch. All right. As a reminder, DCA offers over 20 online DEI training courses in its LMS system. While these courses are not mandatory, board members and board leaders are strongly encouraged to take these trainings as you are instrumental in leading department-wide change. Next, we have an update on the Military Licensing Resources webinar. To support and maximize outreach to our military community, DCA is hosting a second live webinar on November 21st, 2024, to share information about military licensing resources. During the webinar, all attendees will learn about licensing resources available to members of the military and their spouses or domestic partners. The webinar will also feature a demonstration of DCA's Federal Professional License Portal and state registration process, which was launched last fall, as well as a Q&A section. Webinar details and information will be available at www.dca.ca.gov/military. Next, new business and travel expense reimbursement program. The state's Department of Human Resources, also known as CalHR, recently released an updated travel policy to align with the federal policies outlined by the U.S. General Services Administration. Effective October 1st, 2024, DCA will use the federal standard meals and incidental expense rates for in-state and out-of-state travel. DCA will also use the federal standard and non-standard reimbursement lodging rates. Information on these changes was shared with board leaders at the end of September. Board members are encouraged to become familiar with the new travel expense reimbursement program and rates. Please contact Board and Bureau Relations with any questions regarding these changes. Next, Season of Giving. We are officially in the Season of Giving, and DCA is honored to join in the annual charitable campaigns launching this month. DCA's annual Turkey Drive and the state's Our Promise campaign. The Turkey Drive will be on November 13th, 2024 from 8 a.m. to 10 a.m. Board members and employees will have an opportunity to give back to the community. DCA will hold its third annual Turkey Drive with donations benefiting Joey's Food Locker, a local food bank located near DCA headquarters in Sacramento. Donations of frozen turkeys and non-perishable food items will be accepted at DCA headquarters, bar headquarters, and Evergreen building locations in the Sacramento area. For information on how to participate and donate, please contact your executive officer. The items collected during the event are part of the larger state employees food drive that takes place this time of year as well. Later in the month, DCA will announce collection box locations. Next is the Our Promise campaign launch, State Employees Giving at Work campaign. Every year through the Our Promise California State Employees Charitable Campaign, state employees, including board members, have the opportunity to support the nonprofit causes they are passionate about through payroll given or one-time donations. These contributions have a positive impact on our communities and is another way for DCA to show it cares for California. This year's campaign is led by Monica Vargas, Deputy Director of Communications, and Karen Navarro, Assistant Deputy Director of Communications. DCA's campaign officially launches on November 18th and runs through December 31st. In the meantime, please contact Board and Bureau Relations with any questions or if you would like information on how you can give. And again, thank you for this opportunity for me to join you today. I'm happy to answer any questions from the board.
Thank you, Deputy Director Gear. We're very happy you're here in person. Can't believe it's turkey time already. Members, any comments, questions for Deputy Director? All right, seeing none, I think we're ready for public comment. Is the sound like something's going on?
I think someone's cleaning outside the door.
Oh, okay, okay. Okay, any public comment in person? Seeing none, ready for WebEx, David?
We are open for public comment via WebEx. This is agenda item 6, the DCA update. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. For our dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Yes, please. Thank you. Thank you, Deputy Director Gear. We're so happy you're here in person with us. All right, members, ready for next agenda item 7, Enforcement and Compounding Committee. I will now turn the meeting over to Maria Serpa, Chairperson of the Enforcement and Compounding Committee, to provide report on the committee's efforts. Maria, the floor is yours.
If I turn it on. Thank you, President O. On behalf of the committee, I'm pleased to provide the board with a summary of the committee's efforts at our October 16th, 2024 meeting and follow up on outstanding items from our July 17th, 2024 meeting that were postponed from the July 31st, August 1st board meeting. Thank you to my fellow members, Vice Chair Renee Barker, Indira Cameron Banks, Sung Oh, and Nicole Tebow. First item is discussion and consideration of updates to frequently asked questions related to Assembly Bill 1286. Members, as you may recall, that as a part of our discussion on implementation of AB 1286, given the comprehensive nature of the measure, we determined that the development of FAQs was appropriate. The FAQs was initially approved during the February 2024 board meeting. At that time, it was noted that the FAQs needed to be updated as additional questions were received. More recently, the board approved changes to the FAQs during the April board meeting. Members, this item was originally scheduled to be discussed at the July 31st, August 1st board meeting, but was postponed. Attachment 1 includes a copy of the updated FAQs related to reporting medication errors by non-resident pharmacies. You will note that the committee is offering the recommendation to approve the changes to the FAQs. With the committee's recommendation serving as the motion, members, do you have any questions or comments? I can't see Nicole, so let me know.
This is for the FAQs, right?
Yes.
My one comment was just on the discussion that was had regarding the technician-initiated transfers. I saw some of the notes from that, I believe. So it looks like that question was removed. I don't know if there's going to be further discussion with the full board at some point, but I agree with some of the comments that, you know, the typical workflow is that the receiving pharmacy is the one that initiates the transfer.
So that's actually part of the sunset review.
Oh, sorry about that. Mixing things up.
Go ahead, Inez. Okay, yeah, it's gonna be addressed somehow, yeah.
Perfect, thank you.
Hopefully.
Yeah, so the FAQs do not have, that question was removed and there's only one update. Okay, I guess we're ready for a public comment. Public comment beginning in San Diego. Seeing none, moderator, we're ready for a public comment via WebEx.
We are once again open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand. And as a reminder to our mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Yes, thank you. Seeing that there's no additional comments, President O, I turn the meeting over to you for the vote.
Thank you, Chair Serpa. Jesse, how do you vote?
Yes.
Thank you, Jesse. Renee, how do you vote?
Yes.
Thank you, Renee. Jeff, how do you vote?
Yes.
Thank you, Jeff. KK, how do you vote?
Yes.
Thank you, KK. Jay, how do you vote?
Yes.
Thank you, Jay. Satinder, how do you vote?
Yes.
Thank you, Satinder. Maria, how do you vote?
Yes.
Thank you, Maria. Nicole, how do you vote?
Yes.
Thank you, Nicole. And I vote yes, the motion passes. Back to you, Chair Serpa.
Thank you. Next item is presentation on distribution of controlled substances, wholesaler perspective, provided by Leah Lindahl, Vice President, State Government Affairs, Healthcare Distribution Alliance, and Sarah Watson, Manager of State Regulatory Outreach from Cardinal Health. Background information on this agenda item is provided in the meeting materials. As you may recall, the board received public comments from patients and chronic pain advocates about the impacts to patients who are facing challenges receiving their controlled substances. We have also received information on actions taken by the DEA to change allocation quotas for controlled substances, which may have contributed to this issue. As a part of our ongoing education on this issue, during the committee meeting, our committee received a presentation to provide us with the wholesaler's perspective on this issue. The presentation was very insightful. I would strongly encourage everyone to review the live stream posted on our website if you've not had the opportunity to do so yet. During the presentation, we learned about the required use of thresholds and suspicious order reporting and some of the legal constraints for wholesalers in their interactions with their customers regarding thresholds. We learned that threshold changes are possible and that the wholesalers generally have a process to allow customers to make such a request. But the request must come from the customer independently. We have requested that the staff include an article in the upcoming script to provide education and all send out an alert through the listserver, to send out an alert through the listserver. In addition, the committee believes a policy statement may be appropriate, as well as collaborating with the Medical Board of California and other programs within the Department of Consumer Affairs to explore additional solutions. Members, do you have any questions or comments?
Hi, Maria. This is Jessie. My one comment kind of just on the whole discussion of controlled substances is I don't believe it's been extended yet, and someone correct me if I'm wrong, but I believe the in-person waiver for controlled substances of requiring people to see an appointment may be ending in December. But I'm sure we'll find out if it gets extended, but it may be good for us to kind of hold a discussion about that at some point if it doesn't get extended, about how pharmacies are to handle a lot of controlled substances and the excess prescriptions coming in that are coming via telehealth with people who have not been seen in person.
Thank you, Jesse. My comment is I do think this presentation is very helpful. I know it's been talked about, so I encourage everybody to watch this part. Especially the people that's in the pharmacy world, it really shows kind of the insights of a little more background to it. So I think it's really useful. I encourage strongly to watch this.
It was eye-opening to me that the wholesalers are not allowed to contact their customers when they see that there's a need to request a threshold increase, but the customers can request it on their own. So I'm really happy that the board is going to help disseminate that information. So we're ready for public comment. In San Diego? Seeing none, moderator, we're ready for public comment via WebEx.
We are open for public comment on 7B as in Bravo. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. And it looks like our first request is coming from Pat Irving. Hold on just a moment. We're going to send you a request to unmute your microphone. You'll be given 2 minutes to speak, and I'll give you a 10-second warning before your time expires. All right, Pat, I see you've unmuted. Are you with us?
Yes, can you hear me all right?
Yes, go ahead, please.
Perfect. My name is Pat Irving. I'm an RN with over 40 years experience in risk and patient safety. The reason I am commenting is I've had a lot of experience with the thresholds in my research. And one of the things that we found is that it's not as easy as just asking for the increases to happen. It at this time is a very onerous process. There is a lot of fear from the pharmacies that I've contacted involved with this because it requires more scrutiny by the distributor. It often also puts the pharmacy at risk for becoming more publicly noticed by both the DEA as well as the Attorney General. Quickly, before I lose time, it's important to distinguish between the DEA quotas and the thresholds which come from the National Opioid Settlement Injunction. They are two completely separate things, and their ramifications and how we're going to tackle them are very different. I wish the board well in coming and facing these thresholds. It's not going to be as easy as it seems on the surface. Thank you very much.
Thank you.
Our next comment is going to come from John Gray. We're going to send you a request to unmute your microphone. You will probably need to dial *6 in order to unmute if you're connected by a phone only. Hold on just a moment. We're sending you that request now.
Hi, good morning again. This is John Gray, registered pharmacist with Kaiser Permanente. Thanks very much for the opportunity to comment. First of all, just want to say that, Pat Irving's comments just now were just spot on. So thank you for those. We also want to continue to encourage the board to do as much as it can to collaborate with the medical board in going to our Attorney General, the United States Attorney General, and other parties to discuss this really important issue. In our observation with thresholds and thresholds being exceeded, we see them happening in cases where there's a unique patient need for a controlled substance, for example, a patient who's being cared for by hospice, or there are changes in clinical practice based on new data resulting in off-label prescribing of controlled substances. Our observations for cases where thresholds are exceeded is, number one, the distributor's thresholds are insensitive to changes in needs, such as when there's a new off-label use for a drug. Secondly, even in cases of known changes in business practices with advanced notification, the process to get a threshold adjusted is far too slow. While a request for an adjustment is being adjudicated and working through the process, patients can suffer. And third, in some cases, inherent in the distributor's decision to adjust or not to adjust a threshold is a clinical judgment about the appropriateness of the use of a controlled substance in a particular case or set of cases. Distributors are not healthcare providers, and as such, this is concerning and somewhat even argue inappropriate. So those are our observations and the reasons that we think it's incredibly important that the board continue to push this issue in collaboration with the medical board, we hope. Thanks very much for the opportunity to comment.
Thank you.
And that was our last request via WebEx.
Great, thank you. Members, do you have any additional comments before we move on to our next agenda item?
I have a comment. I agree with the callers. I think there's two separate issues. All the distributors are like limited based on their agreements that they have signed. But I think the board really can help with this when number of pharmacies that are closing and when the prescription volume picks up in the other locations. That really causes a problem in terms of getting the medications. Although I think those might be easier to get approved from what the representative from the distributors was talking about. So I think that part really needs to be out soon. Like as soon as some of the pharmacies are not aware of that, and that would be very helpful, I think, to those pharmacies that not aware that if they get pharmacy closed and prescription start to migrate to their pharmacies, they can request this. That's all I had.
Thank you. Any other comments? Okay, next item is discussion and consideration of draft report to the legislature on automated drug delivery systems as required by Business and Professions Code 4427.8. Members, as detailed in the meeting materials, the board is required to submit a report to the legislature on the regulation of automated drug delivery systems, or ADDS, as a part of its upcoming sunset evaluation process. You may recall that during our July 2023 committee meeting, members received the first presentation related to the findings of QA reports received. This revealed in part what appeared to be a lack of compliance in reporting requirements. Since that time, staff undertook education of licensees on the reporting requirements. More recently, the committee received a presentation with updated data at our July 2024 committee meeting. As a reminder, those presentation slides and the live stream of the meeting are available on our website if you are interested. During the October committee meeting, the committee reviewed the draft report, which is provided in attachment 2 of the meeting materials. As a committee, we discussed the report and believe the information is appropriate, including the conclusions drawn from the information received. As indicated in the meeting materials, the committee is recommending approval of the legislative report. With the committee's recommendation serving as the motion, members, do you have any questions or comments?
My only comment is just to applaud staff on the efforts of outreach and compliance. I mean, you can see the difference in the report, which is pretty astonishing, but I think it's such an important aspect of transitioning to new requirements, something that we should be mindful of. I think as we transition to medication errors for pharmacies too, once that's up and running, it's probably going to take a lot of time and effort to make sure that we're reaching out to licensees for compliance.
Thank you. Any other member comments? Okay, let's move on to public comment, beginning with individuals in San Diego. Seeing none, moderator, we're ready for public comment from WebEx.
We are open for public comment on 7C, as in Charlie. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3. And as a reminder to our mobile device users, you may need to hit the ellipses button, it's the ... in order to find your hand. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Yes, thank you. Seeing that there was no public comment, President O, I turn the meeting over to you for the vote.
Thank you, Chair Serpa. Jesse, how do you vote?
Yes.
Thank you. Renee, how do you vote?
Yes.
Thank you, Renee. Jeff, how do you vote?
Yes.
Thank you, Jeff. KK, how do you vote?
Yes.
Thank you, KK. Jay, how do you vote?
Yes.
Thank you, Jay. Satinder, how do you vote?
Yes.
Thank you, Satinder. Maria, how do you vote?
Yes.
Thank you, Maria. Nicole, how do you vote?
Yes.
Thank you, Nicole. And I vote yes. The motion passes back to you, Chair Serpa.
Thank you. Next item is discussion and consideration of enrolled or recently signed legislation impacting the practice of pharmacy. Members, as we do at our fall meeting each year, the committee discussed enrolled legislation that was either signed or vetoed by the governor. The first measure in our discussion is AB 1842 related to healthcare coverage for medication-assisted treatment. The committee noted general agreement with the implementation activities offered by staff. Members, do you have any questions or comments on AB 1842? Seeing none, we're ready for public comment for individuals in San Diego. No public comment in San Diego. Moderator, we're ready for public comment via WebEx.
We are open for public comment on 7D as in Delta. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request, do you wish to continue with the agenda?
Yes, thank you. Our next measure for consideration is AB 1902, related to accessibility of prescription drug labels. As a part of a discussion, the committee discussed the requirements established in the measure and if the statute is sufficient for self-execution. The committee has requested that staff develop additional information about what is specifically required and if regulations are necessary. Members agreed that education on the provisions is necessary and that staff should exercise enforcement discretion during the implementation phase by securing compliance through education. Members, do you have any questions or comments on AB 1902?
I do. I just have a question for members. If you all believe that regulation on this is helpful, or would it actually be more confusing? So just wanted to gather some ideas.
I will say I think this is one of the areas that's going to need a lot of guidance from the board. So I don't really know exactly what that looks like yet. I think cost was something that we had discussed in the Legislation Regulation Committee, and that's something that's definitely of a concern, especially when it comes to the softwares, smaller pharmacies, and whatever technology would be needed. For example, if you need a prescription label in Braille, I imagine that would be pretty costly. I don't know if regulation is necessarily the best way because I don't really know what this looks like in practice. I think there's a lot of unknown about it. I think it's definitely a step in the right direction for patient accessibility. But I'm hoping that we can have an ongoing discussion about this. We may need more meetings and have this as a separate agenda item.
Just a curiosity, was there any discussion with regards to providing the translated label to the patient versus affixing that to the container? Because in my experience, translated labels not necessarily have the same, not every language has the same structure. So it takes more characters in some languages to translate the exact same thing. So is affixing the label to the container something discussed and the committee deems necessary, or just providing a translational label? And it could be a separate piece of paper because, as I said, there is a perfect example is Braille. It may not be possible to put it on a 13-gram vial to put a Braille. So that language would be something I would consider if it hasn't been discussed so far.
So if, just to give you a little bit of information, is there are, I think, quite a few questions. And I think that that's why the committee asked staff to do a little bit more evaluation to find out if we could, if regulations would be needed to assist with the educational efforts, or if solely educational efforts will be required. So this will be continued to be discussed in our committee.
I do want to say, I think there are some things in there that would benefit from a regulation, just to clarify. And doing so would hopefully reduce any, I pointed out during the meeting about like what is a timely manner. And that could be an hour to some people, that could be 30 minutes to some people, that could be 10 minutes to some people. And I think that could cause some confusion. It does clearly lay out its use of audible, large print, Braille, or translated directions. So I'm hoping that there's a flexibility that we could provide more guidance as well. So I'm sure we'll be talking more about this at enforcement meeting, but if you all have any strong desires on one way or the other, it would be good to let Chair and us know as well. And it is really early, so I'm sure there are some times to talk about it.
Okay, I think seeing no more comment from the board, we're ready for public comment, beginning with individuals in San Diego. Seeing none, moderator, we're ready for public comment via WebEx.
We are open for public comment on 71 or 72. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial in users, dial *3 to raise a hand, and we will call on people in the order we have requests. And as a reminder to our mobile device users, you may need to hit the ellipses button. That's the ... in order to find your hand. We're going to start with John Gray. You may need to dial *6 in order to unmute. I'll give you 2 minutes to speak, and I'll give you a 10-second warning before your time expires.
Thank you very much. Good morning. This is John Gray. Afternoon. This is John Gray, registered pharmacist with Kaiser Permanente. Thanks for the opportunity to comment. So, you know, I will say, you know, our Kaiser Permanente, our policies and based on federal law already require that we offer and provide information in alternative formats to our patients upon request. So we may be slightly differently positioned from some other folks in the regulated public. Our impression of the requirements of the bill is that we generally understand what is expected by the bill and are not sure that regulation is necessary. However, I will say I really appreciate Dr. O's comment around the timeliness standard that was included in the bill. And, you know, if the board feels regulation is necessary to clarify that, I think we would agree that that would be an area that might benefit from some clarification, particularly because, you know, for anyone who's worked in a pharmacy, just the process of providing either a translated label or an alternative label, just by definition requires more steps, right? As the pharmacist, you're going to do your usual process to generate, you know, quote unquote, a conventional label. But then when the patient requests a translated or alternative format label, there are additional steps such as enlarging the print, running it through a Braille printer, putting together the elements required to make the talking vial work. So we do appreciate the kind of board's view that this is going to take some time and would benefit from clarification around the timeliness standard. Thanks for the opportunity to comment.
Thank you.
Next, we're going to hear from Stephen Gray. Hold on just a moment. We're going to send you a request to unmute your microphone.
I agree completely with the previous speaker, John Gray from Kaiser Permanente. The experience I had with Kaiser Permanente, there were Braille systems available to meet the federal requirements, but they weren't very timely. For an example, the information would be transmitted to Portland, Oregon, and Portland, Oregon would deliver a Braille document back within 24 hours. And I don't know if there's really any practical way for each pharmacy to have something on hand in order to provide that. That at the federal level was considered a reasonable accommodation. So we have some issues there. The other thing, my comment is, this bill, the law was effective January 1, as I understand it. There was no delayed implementation built into the statute. And I think, though, the Board of Pharmacy may have some discretion regarding the administrative liability that a pharmacy may have regarding the board, the civil liability may take effect immediately. And so I would be careful not to misguide the pharmacies out there that because the board gives some time for some discretion and delay, the civil liability may not be so forgiving. So with that in mind, I think a board needs to be very careful how it proceeds. Thank you.
Thank you.
And those were our only requests for comments on this item.
Great, thank you. Our next measure for discussion is Assembly Bill 2115, authorizing specific entities to dispense a 72-hour supply of a Scheduled II controlled substance for the purpose of relieving acute withdrawal symptoms while arrangements are being made for the referral for treatment. As a committee, we noted agreement with the implementation activities identified by staff. Members, do you have any questions or comments on AB 2115? Okay, then we're ready for public comment. Beginning in San Diego. Seeing none, moderator, we're ready for public comment via WebEx.
We are open for public comment on 7D3. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise a hand. And for our mobile device users, you may need to hit the ellipses button. That's the ... in order to find your hand. We're going to take just a few seconds now to see if we have a request for public comment. All right, it looks like we have a request from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you. Another pharmacist attorney and I worked a lot with the City County of San Francisco on this bill. It's a very important bill, and I think it deserves a lot of publication and education by the Board of Pharmacy. It's designed to really save patients from fentanyl deaths by giving basically 72 hours to get them enrolled in a maintenance program, during which time they may be going through extreme withdrawals and seek other drugs on the street and then end up with fentanyl and dying. So that's what this is all about. I hasten to mention that there's a related bill which requires the medical board and others to disseminate information to their licensees about this new provision, this new ability to take care of these patients. And I would encourage the board, which I'm sure it will, but encourage the board to work carefully with the medical board and others so that the communication that goes out is similar, if not exactly the same. And that includes information to the hospitals, because the bill does allow this 72 or 3-day supply to also be dispensed by hospitals. Thank you.
Thank you.
And those are all of our, that's our only request for this comment period.
Thank you. And just for the board's information, Dr. Gray gave you a preview of a coming up bill, so we'll be talking about that also. Unless you have any questions right now, we'll be talking about that in just a minute or so. Okay, thank you. Our next measure for discussion is AB 3063, related to adding flavoring to prescription medications. I note that this is the second year the governor has vetoed this measure. The board opposed this measure as it conflicts with USP standards, but does see a potential to assist pharmacies to continue to provide flavoring. I note that the meeting materials include the amendment that the board requested of the author of the legislation to address the board's concern. Regrettably, the amendment was not accepted. As a reminder, USP recognizes the addition of flavoring as compounding, and the USP does have an FAQ on the use of flavoring agents. This FAQ was previously sent out to California licensees to assist them with the transition. Following our discussion, the committee recommended that the board develop potential statutory language related to flavoring agents and prescription requirements. As I noted during the committee meeting, the proposed legislation would not change USP requirements. And just to be clear, we don't have the ability to change USP requirements. So our proposed legislation would allow pharmacies to make flavoring additions without obtaining the prescriber's authorization each and every time. This would be within the board's authority. Members, I want to ensure that everyone received the public comment on this item. There was a public comment that was sent. It's from one of the manufacturers of the flavoring agents. I have read the comments and note that unfortunately it appears that the commenter is again requesting the board to disregard national standards. I remain steadfast in my belief that the board needs to focus on assisting pharmacies to operationalize the USP requirements. I believe it's appropriate to remind members that the governor has vetoed this on 2 different occasions that would have changed California law to run contrary with national standards. Flavoring is a great tool in assisting medication palatability. I think we all agree on that. The board would like to assist pharmacies to continue to offer this service within the current national standards. As I open for discussion, I note that the committee's recommendation serves as a motion, but I would still appreciate members' comments on this issue. Members.
So I was going through some of the messages, and I think there's this one, I hope I'm not going out of order again, the package insert that was here. I noticed that the package insert included in the materials is for brand name Augmentin,
Were we provided examples of generics? Because I can just say at my pharmacy, I know that the brand name is not going to be covered for my patients, and most people won't be able to access it. So I'm just wondering if we have any information about whether the flavoring is included in package inserts for generic medications that are most likely to receive flavoring.
I think that was an example that was provided, and I think that's a great question. But I think what we're looking really at is providing the pharmacies the authority to add flavoring without contacting the prescriber. So it would not only just be adding flavoring as in the package insert. I think that package insert was just an example for. Anne, do you have any additional information?
Yeah. So I think that that package insert was provided as an example of where the FDA says it's not considered compounding, right? So I'm not quite sure I can totally answer your question, but I think what the policy consideration before the board right now is, are there things that we can do to help operationalize compliance with the standard so that people that maybe don't have access to the augmented and require the generic, is there a way that we can help facilities operationalize so that you can flavor it?
I think I understand the objective, and I think having some sort of access for pharmacies to initiate it without a doctor prescription is definitely important. I think my concern more so is with some of the public comment that was stated, which is that this may not make a difference, because if the flavoring instructions is only for brand name medications, that may not be super impactful. There may not be many people who actually receive brand name only medications versus if there is generic that has an outline.
I think that, certainly those of you that practice in the outpatient arena would know this better, but we commonly add flavoring agents to medications that it doesn't specifically say anything in the package insert. So I think that's within the pharmacist's judgment whether the patient requires flavoring, and that would still be an option whether or not it's actually listed in the package insert.
Hi, this is Renee. I mean, your point well taken, right? The generic versus the trade or the brand. But here, like, they've done the extra steps of the stability with the flavoring in it, right? So that's why it's in this one, but it doesn't necessarily apply. So, I think that's part of the fact that it's considered compounding, because it's, another ingredient to add in and all that. So, so it's like, unfortunately, like other generics would really have to have that information to really provide that like confidence.
And I agree with the language being being presented. It's more so just a question of how much this will actually change in terms of the world of flavoring. That's pretty much it.
Mm-hmm.
So I concur with Jesse, although, some of the concerns that were raised, that how to operationalize it and how it could be interpreted. I think in light of like that, we can't contradict what the veto message was. And I think one of the solution provided was to adapt a similar legislation to Minnesota one. But I think that contradicts what the veto message would be, so that I don't think that's an option. So this language, and I feel like we also need to provide it some sort of an FAQ regarding documentation, because the documentation, we leave that as a compound. It's very, it would take way too much time for a pharmacist and community pharmacies to pull out and do all the documentation and be able to dispense. So along with in FAQ, not just this language, if you can also provide some, like the USP has a documentation standards, if you can carve out some sort of like a documentation there that makes it easier for pharmacists to not follow the whole entire thing and be able to carve out exceptions, some sort in there.
Thank you. I think it would be helpful to if members feel comfortable, are there any other like aspects that we can like consider so we're not like piecemealing if possible? Are there other things within the standards that you're like, can you give us guidance on how to operationalize or what that could look like? So we've got the statute piece, which is the prescription piece, right? But not having to go. And then the documentation. Does anyone feel comfortable? Are there any additional ones that you're like, you know, this we might need to figure out a way to address, if that makes sense?
I mean, I don't know if this is too much work, but if there is a way for staff to kind of research some of the commonly like mixed medications, I think specifically for pediatrics, it tends to be the highest population for flavoring, but some of like the amoxicillin, cephalexin, the antibiotics that actually include flavoring stability in the package insert and have a list available to licensees, I think that would be helpful as part of maybe like an FAQ or something. But I know that will be a lot of work, so I'm sorry ahead of time.
Okay. I think we're ready for public comment. Public comment in San Diego. Someone's coming to the table.
That good? Okay. Good afternoon, everyone. My name is Chad Baker. I'm the Senior Vice President of Government Relations at FlavorRx. Thank you for the opportunity to provide comments today. I'll begin by reemphasizing a few statements from my written testimony. First, for those of you who are new to the topic, medication flavoring is one of the best tools pharmacies have at their disposal to help young children take their liquid medications so they can get better. It is a time-tested, lab-tested, safe, effective, and almost everywhere widely available core pharmacy service. Second, there are now fewer pharmacies offering flavored medications in the entire state of California than most Americans have within a 5-minute drive of their homes. Wyoming, with roughly 1.5% the population of California, has 5 times more pharmacies that offer flavoring for children's medications than California. It wasn't always this way. A year ago, over 3,000 California pharmacies offered medication flavoring. Now, by our latest estimates, that number is less than 10. I would like to comment on the materials provided to you by the board staff. The report coming out of the committee meeting missed the point. The issue is not whether the FDA or USP or APHA or AVMA consider medication flavoring to be compounding. In fact, 4 other state boards of pharmacy also clearly say in their rules or guidance that flavoring is compounding. Yet pharmacies in those states and nearly all others for that matter continue to provide this service, this important service to their customers without pause. The real issue lies in how you decide to regulate the practice of medication flavoring. Will you continue to expect pharmacies to abide by all USP 795 non-sterile compounding standards as pertains to flavoring, or will you give them a break? It is true California is relatively unique and that you are statutorily bound to abide by USP standards. But again, this misses the point. 3 other states have the exact same statutory requirement to abide by USP standards. And these 3 states, Georgia, Virginia, and Minnesota, medication flavoring continues to be widely available. They figured out a way, so can you. I would offer there are no generics that have flavoring on the package insert. It was just that Augmentin. So you don't have to do a lot of research. Thank you.
There's no more comment here in San Diego, so we're ready for public comment via WebEx.
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise a hand. And for our mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand. We're going to start with Chloe King. Hold on just a moment. We're going to send you a request to unmute your microphone. Chloe, are you with us?
Yes, hello.
Yes, go ahead, please.
Thank you. Thank you to the board for hearing this item today and for the opportunity to comment. My name is Chloe King and I'm providing comments on behalf of the Children's Specialty Care Coalition, an association that represents over 3,000 pediatric specialists throughout California and whose mission is to ensure that children and youth with complex health needs have access to equitable, timely, and high-quality care. Flavoring of medication is widely regarded as one of the most effective tools pharmacists have to help children take their medicine. Restricted access to flavored medicine creates an unnecessary barrier for children and their families, many of whom are managing chronic conditions that require regular, long-term use of medication and sometimes multiple doses per day. Medication flavoring is safe, yet since the board began applying the new USP 795 non-sterile compounding standards to this well-established practice, we have seen access plummet. Unfortunately, the language you are considering, which was proposed by the Enforcement and Compounding Committee, is not sufficient to bring flavoring back to California pharmacies. Pharmacies must have clear guidance that the USP 795 compounding standards do not apply to the practice of medication flavoring. We urge you to adopt a solution that will give pharmacies the assurance they need to resume providing this critical service that so many children and youth depend on. Thank you for your time.
Thank you.
Next, we're going to hear from John Gray. You may need to dial *6 in order to unmute. I'm sending you a request to unmute your microphone.
Yes, thank you very much. Good afternoon. This is John Gray, registered pharmacist with Kaiser Permanente. Just want to primarily share with the board that, while we appreciate the continued interest in finding a path forward on this, the proposed statutory language would very likely not influence our decision on whether or not to offer flavoring services within our pharmacies. If you take the example of an outpatient pharmacy that does not offer any other compounding services, and in order to offer flavoring to its patients would have to meet every requirement associated with USP 795 and the board's proposed non-sterile compounding regulations, the juice simply isn't worth the squeeze, and so we would almost certainly continue to not offer those services in our outpatient pharmacies, even if this statutory language went through. I'll also just add that, like the board's approach to the rest of the compounding regulations, it feels as though the board is choosing to take the most dogmatic approach to regulating an issue without any real evidence to support it. If you look at the evidence provided by other folks who have been active in commenting on this, flavoring is a safe tool that helps kids take their medicine, and without it, I have to believe that parents are probably, adding liquid medication to chocolate milk, which might be
10 seconds.
Inactivating the medication in certain cases. So we just don't see the reason for the dogmatism on this particular matter. Thanks for the opportunity to comment.
Thank you.
Next, we're going to hear from John Teague. Hold on just a moment. We're sending you a request to unmute your microphone.
Greatest.
John Teague?
Yes.
Are you ready?
Can you hear me? Hello?
Yes, go ahead, please.
Sorry, my microphone's not the greatest. So I'm Director of Pharmacy at Pioneers Memorial Healthcare District out in Brawley, California, and owner of Desert Pharmacy in El Centro, California. And I agree with what John had to say. Flavoring for kids is especially necessary, especially those with special needs. And the chocolate milk example hits the nail on the head. So I've had several physicians call me very upset, and they've actually used that very example that they feel really concerned that parents would be adding different things to medications for their kids, and just worried about the effectiveness of those medications. And, I just appreciate your consideration and trying to make this easier for our pharmacies and for consumers out there. So thank you.
Thank you.
Those are all of our requests for this item.
Thank you.
Wait, I misspoke. Next, we're going to hear from Crystal Frost. Hold on just a moment. We're going to send you a request to unmute your microphone. And for anyone else, don't be afraid to put your hand up early. It can stay there. I promise it won't get tired.
Hi, Hi, everyone. I just wanted to briefly address the board. Thank you for the opportunity to comment. Usually you all hear from me regarding the proposed updates on sterile compounding, but I just want to briefly comment and say I support and second previous comments on this matter. Medication flavoring is safe and effective, and I know you all are aware of this. Please reconsider your aggressive stance on flavored medications that are not founded in science. This proposal harms countless Californians, including children, disabled individuals, and elderly. And you're likely putting parents in a position where they're going to have to mix their own kids' medicines, which is very dangerous. And this will affect disabled individuals and elderly as well. So please adopt a real solution that restores access to flavored medications in California. Thank you.
Thank you.
All right, I believe we're finished this time.
Great, thank you. Members, I think you have heard not only from the public, but from members of the board and of the committee that this is an important issue. This is why we have brought it back up, even though this has been brought up during the legislative cycle and vetoed twice. We still see that there is a need that was not met by previous legislation, and believe that the board could come up with some intermediate solution that would meet the needs of patients, parents, and still meet the need of documentation and USP standards. So we're proposing this regulatory or statute route with the very first recommendation. You could see that we still have lots of discussion. And so what I foresee that the statute will not be the way it's written. It is now, though I think there'll be ongoing discussion. So my suggestion to the board is to allow the committee to continue to work on the statute by voting yes on this first step so that we can continue the discussion and potentially add additional language to make it more beneficial and easier to implement. That's my suggestion. So with that, I think I do need to ask members, do you have any additional comments or questions before we go to the vote? Okay, President O, I turn the meeting back to you for the vote.
Thank you, Maria. Jesse, how do you vote?
Yes.
Thank you, Jesse. Renee, how do you vote?
Yes.
Thank you, Renee. Jeff, how do you vote?
Yes.
Thank you, Jeff. KK, how do you vote?
Yes.
Thank you, KKJ. How do you vote?
Yes.
Thank you, Jay. Satinder, how do you vote?
Yes.
Thank you. Maria, how do you vote?
Yes.
Thank you, Maria. Nicole, how do you vote?
Yes.
Thank you, Nicole. And I vote yes. The motion passes. Back to you, Chair Serpa.
Thank you. The next measure for discussion is SB 164, which raises the cures fees from $9 annually to $15 annually. Implementation of the new fees will be facilitated by the Department of Justice. As a committee, we agreed with the implementation activities detailed in the meeting materials. Members, do you have any questions or comments on SB 16 or 164? Seeing none, we're ready for public comment. Any public comment in San Diego? There's no public comment in San Diego. We're ready for public comment via WebEx.
We are open for public comment on 7D5. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. For our dial-in users, you'll need to dial *3 to raise your hand. And for our mobile device users, you need to hit the ellipses button, that's the ... if you're having trouble finding your hand button. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Yes, thank you. The next measure is Senate Bill 954 was vetoed by the governor. This measure was about access to non-prescription contraception. During the meeting, members noted the need to provide education on the existing law. Attachment 4 includes the subscriber alert released on February 2024 describing the rights to contraceptive care. This information will be also included in a future issue of the script. Members, do you have any questions and comments on SB 954? Okay, seeing none, we're ready for public comment in San Diego. It's tough because they both start with S. Sacramento, San Diego. Seeing none, we're ready for public comment via WebEx.
We are once again open for public comment. This is 7D6. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Yes, thank you. The next item is Senate Bill 966 that was also vetoed by the governor. Senate Bill 966 would have established the regulation of pharmacy benefit managers within the California Department of Insurance. As indicated in the meeting materials, the board has also identified payer practices that negatively impact patients as a possible issue to include in the sunset review. As we will be discussing this issue as a part of new issues for sunset review under a separate agenda item, I don't believe we need to have extensive discussion on this issue at this time. In the meantime, members, do you have any questions or comments on Senate Bill 966?
Sorry, I just want to express my disappointment that this was vetoed. Feels like we're kind of back to square one again. I know this has been vetoed several times, or PBM regulation several times in California. So I'm hoping that we can figure out something in the future.
Any other comments from members? Say we're ready for public comment. Any comment in San Diego? Seeing none, we're ready for public comment. Oh, sorry, someone's coming up. Hi. Sorry about that. We have comment here in San Diego.
Sorry. Thank you for the opportunity. My name is Sean Kim. I'm from California Pharmacists Association. As you mentioned that we have provided a comments to include this in the sunset review. Here to voice support the adding the PBM. We can talk more later in the time, but it was such a disappointment for seeing the veto because it really affects on the consumer protection side. These limitations restrict on consumers from accessing their preferred local pharmacies, as well as they rely on personalized care and consultation. Such restrictions are detrimental to patients' health, particularly those who require consistent access to medication and support from the trusted provider. Patients deserve the freedom to choose their pharmacies and timely access to their medications, which is crucial, avoiding emergency care and hospitalizations due to delayed treatments. PBM regulation is essential, restoring fair practices that protects consumers' rights and their safety. Including these in the sunset review would be a step forward, improving access, patient choices, and the quality of care across the California. I believe we'll discuss more later in the time, but thank you so much for allowing time to comment on this very important topic.
Thank you. There's no more public comment in San Diego, so moderator, we're ready for public comment via WebEx.
First, we're going to call for Richard Dang. By the way, we are open for public comment via WebEx. If you'd like to make a comment, raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand. And mobile device users, you may need to hit the ellipses button. That's the ... in order to find your hand. Now we're going to call on Richard Dang. Hold on just a moment. We're going to send you a request to unmute your microphone.
Hi, Richard Dang, commenting as an individual this time. I do also want to express my disappointment in the governor's veto. I do want to put it on the record that there are 25 other states in the United States that license PBMs. California would not have been the first. In the veto message, it was indicated that there is a lack of data that is being sought. And I would like to point out for the record that there is plenty of data on the impact of PBM practices, not only on patient experiences and pharmacy closures, but also on drug prices. And I would encourage individuals seeking that data to look at the published literature, specifically from the USC Schaefer Center for Health Economics and Policy. as well as to refer to the countless hours of testimony received by the Federal Trade Commission over the last 2 years, and to refer to the numerous lawsuits that have been placed against PBMs by different states and different entities over the last few years. So this remains an important issue, and we appreciate the board's reconsideration of revisiting this in the sunset review process. Thank you.
Thank you.
And that was our only request via WebEx.
Great, thank you. Next measure is Senate Bill 1067, was also vetoed by the governor. This measure was about expediting the licensure process in specific situations. Given this measure was vetoed, the committee did not discuss this measure. The next measure for discussion is SB 1089, which will require a covered establishment that includes a pharmacy to provide 45-day advance notice of any closure to the board. As indicated in the meeting materials, the board has pending regulations to amend 16 CCR Section 1708.2 related to discontinuance of business requirements to require at least 30 days notice. During the committee meeting, we noted the board's proposed regulation language should align with the timeframes included in SB 1089. Should the board agree, the staff will work with council on the best means to align the reporting requirements with the statutory provisions. Members, do you have any questions or comments on SB 1089? Okay, seeing none, do we have any comments in San Diego? No comments in San Diego. Moderator, we're ready for comments via WebEx.
We are open for comment on 7D8. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. For our dial-in users, dial *3 to raise your hand. We will call on people in the order we have requests. And our first request comes from Jesse Jawal. Hold on just a moment. Or Graywall. We're going to send you a request to unmute your microphone.
Good afternoon, board members. This is Jassy Graywall with UFCW, the sponsors of SB 1089. We would also concur with the board's recommendation to align the regulations with the timeline proposed in the legislation. Another just comment that would be really helpful for the board to release is an FAQ or guidance to licensees on how the board would like to receive notice in advance of any closures. We think that this type of guidance would be really helpful to pharmacists or to licensees in order to be able to accurately be able to send those notices and know exactly where to send those notices. Thank you for allowing me to make comment today.
Thank you.
And that was our only request via WebEx.
Great, thank you. Members, as it appears that we have agreement on the staff's recommendation to update the proposed regulation text to 45 days to align with this new requirement, I request that staff work with council to determine the best and appropriate path to move forward to facilitate this change. Next item is SB 1451. This was not discussed at the committee meeting, but this measure, just to remind everyone, extends the provisions for pharmacists furnish COVID-19 oral medications until January 1st, 2026. In addition, the measure requires a pharmacist to provide, at the request of a customer, documentation specifically designed for veterinary drugs. I agree with the implementation activities detailed in the meeting materials. I appreciate the information that was provided by the Veterinary Medical Board and appropriate resources to include as a part of the board's education. I also want to ensure that members also received the written public comment that was submitted on this item. Members, did you receive the additional written comments? Great. Do you have any questions or comments on SB 1451?
I do have a comment. I read the public comment as well. I thought it was a little strange requiring the documentation for veterinary medicine, but I will say as an individual, I actually have my own subscription to Plumes just because I have 5 dogs. And I actually use that in my own pharmacy. So I spend my own money to make sure that I'm calculating the dosing and printing out the monographs from plumes in addition to what's in the package insert. What's in a package insert is specific to humans and may not necessarily be the same thing for animals. And it's going to vary from animal to animal and what sort of side effects they may have, et cetera. And so I think this is a really important thing that staff will probably need to collaborate with the veterinary medical board to figure out the best execution for this. And as a side note, I highly encourage that pharmacists do subscribe at least to something so that we're actually appropriately calculating the dosing, because most veterinary medicine is weight-based dosing. That's my last note on that.
Great, thank you. Any other comments from members? Okay, we're ready for comment in San Diego. Okay, moderator, seeing none in San Diego, we're ready for public comment via WebEx.
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Yes, thank you. Members, the final measure for discussion is SB 1468. This was the one that we previously previewed. This measure will require the board, as well as other DCA healing arts boards that license prescribers, to develop and biannually disseminate educational materials about the federal 3-day rule. This was the issue that was previously mentioned in AB 2115, which authorizes dispensing of not more than a 3-day supply of narcotic drugs for the purposes of initiating maintenance treatment or detoxification treatment while arrangements are being made for the referral of treatment. As I noted during the committee meeting, I believe that it would be appropriate to request that the Communication and Public Education Committee oversee the development of educational materials if DCA does not coordinate such a development. Members, do you have any questions or comments on SB 1468? Seeing none, any comments in San Diego? Okay, moderator, there's no comments in San Diego, so we're ready for public comment via WebEx.
We are open for public comment on 7D11. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand. We will call on people in the order we have requests. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, thank you. Okay, we're moving on to E, discussion and consideration of FDA actions related to the implementation of the Drug Supply Chain Security Act. Members, the meeting materials include background information on the Drug Supply Chain Security Act, also referred to as DSCSA. Over the years, the board has received presentations on the implementation activities, including a presentation by Josh Bolin with the National Associations of Boards of Pharmacy. As you may recall, DSCSA included milestones for implementation. Most recently, by November 27, 2023, the law required all prescription drug packages to be serialized with a unique identifier. The FDA has released a number of guidance documents on DSCSA requirements and recently released information that they are issuing exemptions to small dispensers under specified conditions. As indicated in the meeting materials, no action on this item is required by the board or by the committee or the board. Rather, this information was included as a means to ensure licensees and other interested stakeholders remain apprised of activities undertaken by the FDA to implement DSCSA. Members, I note that the provisions of DSCSA relate to track and trace requirements are very complex. As I stated during the committee meeting, I believe it is extremely important for licensees to remain educated on the implementation milestones and the FDA's activities. Such information is available on the FDA website, and I do appreciate staff keeping us informed as new information is released. Members, do you have any questions or comments? Seeing none, we're ready for public comment in San Diego. No comment in San Diego. Moderator, we're ready for public comment via WebEx.
We are open for public comment on 7E as an echo. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, please dial *3 to raise a hand, and we will call on people in the order we have requests. As a reminder to our mobile device users, you may need to hit the ellipses button. That's the ... if you're having trouble finding your hand button. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, thank you. And thank you everyone for your patience. We're on the last item for my report, and that's F, enforcement statistics. The meeting materials include a summary of enforcement statistics for the first 3 months of fiscal year 2024-25. The board has initiated 706 complaints and closed 764 investigations. As of October 1st, 2024, the board has 1,918 field investigations pending. The materials provide a breakdown of the average time frame for the various stages of the field investigation process. Members, I welcome your thoughts on the enforcement statistics. Seeing none, we're ready for public comment. Any public comment in San Diego? Moderator, there's no public comment in San Diego, so we're ready for public comment via WebEx.
We are open for public comment via WebEx on 7F as in Foxtrot. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Yes, thank you. Thank you everyone for your patience during my report. President O, I turn the meeting back to you.
Thank you, Chair Serpa. It is 12:49. We do need to take a lunch. So we'll take a lunch for about an hour. So if we can come back at, let's just call it actually 2 p.m. We're trying to figure out what we can get. So we'll come back at 2 p.m. Sorry that we have to take a lunch break for labor laws and such as well. So we'll be back at 2 p.m. See you later. Bye, everybody. Thank you. Are we live? All good to go? Okay, we're ready to get started. All right, welcome back. Just take a quick roll call. Jesse?
Licensee member present.
Thank you, Jesse. Renee?
Licensee member present.
Thank you, Renee. Jeff?
Public member present.
Thank you, Jeff. KK? Oh, KK's not back yet. We'll go to Jay.
Public member present.
Thank you, Jay. Satinder?
Licensee member present.
Thank you, Satinder. Maria?
Licensee member present.
Thank you, Maria. Nicole?
Licensee member present.
Thank you, Nicole. And I am here, and we'll just keep an eye out for KK's return. Oh, there's KK. We're getting started, KK. All right. Moving on to the discussion. And so on the licensing committee, first item, discussion and consideration of proposal follow-up survey on working conditions. You may recall that as part of the board's prior sunset review, the board committed to conducting a survey on working conditions in community pharmacies. The survey was conducted in 2021 with the data released in December of 2021. During our meeting, the committee determined that it is appropriate to conduct a follow-up survey to gauge current working conditions and gain insights from pharmacists on the implementation of provisions, including AB 1286, related to working conditions. As noted in the meeting materials, the committee also determined it would be appropriate to survey pharmacy technicians as well. As announced during the committee meeting, experts within the DCA's Office of Professional Examination Services will again assist the board if we determine deployment of a survey is appropriate. Following the committee meeting, I worked with staff to develop the 2 surveys that are included in attachment 3, with the committee's recommendation serving as a motion. Do you have any questions or comments on the draft surveys or the committee's discussion and recommendation? Members?
I do have a comment. I know we kind of talked about this more, but I think in addition to some of the other questions that we've already discussed, which include a lot of the same ones, I would probably also add questions that touch upon if there's consequences for not providing certain services. So for example, maybe you have to do like an action plan or attend additional meetings. And I think there was something else that I was looking at. I think that's the only one that I think of, but if I think of anything else after the public comments, I will let you know.
Thank you, Jesse. Any other member comments? No? Okay. With the committee's recommendation serving as a motion, we're ready for public comment in San Diego. Seeing now we're ready for public comment in WebEx.
We are open for public comment on agenda item 8 in the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. For dial-in users, please dial *3 to raise your hand. And as a reminder to our mobile device users, you may need to hit the ellipses button. That's the ... in order to find your hand. We're going to start with Jassy Graywall. Hold on just a moment. We're going to send you a request to unmute your microphone. You'll be given 2 minutes to speak, and I'll give you a 10-second warning before your time expires.
Hi, good afternoon. Jazzy Graywell with UFCW. Strongly support this survey and the additional question by Board Member Crowley. There's a couple other questions that I think could be really helpful in assessing whether just the current working conditions and if pharmacists and pharmacy technicians are able to take on additional patient care services. I'm happy to propose where we would suggest these changes, but just some of the questions that we think would be helpful to include are: what changes do you believe would help you provide additional patient care services? Do you believe you can safely take on more patient care services? Do you believe you have sufficient time to properly screen before providing other clinical services? And do you believe you have sufficient staffing to properly screen before providing other clinical services? I'm happy to share these questions in writing to the board, but we think that these questions are important because they help to assess whether pharmacists and technicians, given their current working conditions, can actually take on more clinical services. And if not, what are the protections that they need in place in order to be able to take on that additional workload? Thank you.
Thank you for the comments, Jassy. And I'm sorry, everyone. I jumped to agenda item 3 in licensing committee. Just not having any food. I'm a little bit, my brain is not functioning as properly. I apologize. So we're on agenda item C in licensing. We jumped ahead. So apologies, everyone. We're going to go back to agenda item 1 after this discussion.
Next, we're going to hear from Richard Dang. Hold on just a moment. We're sending you a request to unmute your microphone.
California Pharmacists Association. Looking at the survey and some of the proposed new questions, I agree and understand the intent of what we're trying to gather. I do just want to point out that some of the questions specifically asking whether they're complying with certain regulations may read as potential concerns for some respondents where they may not want to be identified for potential enforcement on their own license. So I would rather people feel comfortable answering honestly and not fear any retribution or enforcement action afterwards. So I would just ask or recommend some verbiage to reinforce that this would be an anonymous survey and will not be used for enforcement purposes. Thank you.
Thank you, Dr. Dang.
And that was our last request on this comment period.
Thank you so much. All right, with the public comment And we're ready for a vote. But
Sorry,
Jesse,
yeah, I do have one more. The last piece that I wanted to discuss was just over autonomy and specifically with scheduling systems. So now that I've been through a flu season, hopefully we're at the tail end of it with AB 1286 in place. One of the biggest issues that I've experienced and many of my colleagues has expressed is that we don't have control over scheduling. So even though we legally are allowed to decline something if we don't feel like we have sufficient time or staffing, we don't have control over the advertisement over free walk-ins or appointment systems. And so I think getting a better perspective over autonomy and specifically with scheduling those services would give us a bigger perspective or a more clear perspective of what our pharmacists are actually dealing with. So something along the lines of, do you have control over the scheduling system or scheduling clinical services at your store? Essentially asking, are you able to decline? Are you able to cancel appointments? Something along those lines.
thank you, Jesse. I believe the motion is broad enough, Corinne, for us to incorporate that into the question without having to change the motion, right? I know that big timer is just, we're taking the screen, but. Okay.
Sorry.
Okay.
Yes,
That's sufficient
so.
for N and I to work on it and release. Okay. All right. Sounds good. Thanks, Jesse. With that, any other member comments? Ready for vote, Jesse?
Yes.
Thanks, Jesse. Renee?
Yes.
Thank you, Renee. Jeff?
Yes.
Thank you, KK?
Yes.
Thank you, Jay?
Yes.
Thank you, Satinder?
Yes.
Thank you, Maria?
Yes.
Thank you, Nicole?
Yes.
Thank you, and I vote yes. The motion passes. Okay, apologies again, everyone. I'm going back to the first agenda item under Licensing Committee. So first, it's presentation by the California Pharmacists Association on Assembly Bill 317, Weber, Chapter 322, Statutes of 2023 related to pharmacist service coverage. As included in the meeting materials, Assembly Bill 317 established requirements for healthcare service plans and certain disability insurers to reimburse the cost of services performed by a pharmacist at an in-network pharmacy or by a pharmacist at an out-of-network pharmacy under specified conditions. During the meeting, we received a presentation from members of the California Pharmacists Association on the status of the implementation. You may recall that the California Pharmacists Association was a sponsor of the measure. The presentation was very informative. It was a bit disheartening to learn about the barriers that continue to exist of pharmacists to receive reimbursement, but I remain hopeful. I would encourage everyone to watch the live stream of the meeting if you have not had an opportunity to do so. I also call your attention to attachment 1 to the meeting materials, which includes a copy of the presentation slides. Members, any questions or comments? Seeing none, we're ready for public comment in San Diego. Dr. Yoshizuka flew in from Hawaii, I believe.
Thank you for the attire. I didn't know it was showing up in person. Yoshizuka. I was encouraged by, sorry, it's not on. Ah, there you go. Sorry. Keith Yoshizuka. I was encouraged by the report where he said anecdotally that the insurers, the payers, really didn't have a big issue with the restriction that the services had to be rendered within the four walls of the pharmacy, and that might be open to services rendered in an ambulatory care clinic. Even though that wasn't a formal offer, I was encouraged by the fact that they had mentioned that, and it opened some doors for us to pursue. So that's my comments. Thank you.
Thank you for the comments, Dr. Yoshizuka. Seeing none, we're ready for public comment in WebEx. Okay.
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, please. Thank you, David. Members, any other comments before we move to the next item? Seeing none, we're ready for next item is B, discussion and consideration of proposed changes to board provided training for furnishing HIV PrEP and PAP. Members, as included in the meeting materials, recent changes in California law have updated the provisions for pharmacist furnished HIV pre-exposure prophylaxis or PrEP. To address these changes, the board adopted emergency regulations. In addition, it is appropriate to update the board's training program to incorporate the changes in statutes as well as standards for pharmacists furnished HIV PrEP and PAP consistent with the statute. As I stated during the committee meeting, I would like to thank all of the experts that have assisted the board with updating the training program, including Dr. Betty Dong, Dr. Clint Hopkins, experts with the Office of AIDS and Department of Healthcare Services. As indicated in the meeting materials, following approval by the board, Dr. Dong will finalize the program and quiz. The training will be deployed on the board's new learning management system. Members, the training program slides are included as attachment 2. As a committee, we consider the training materials and are offering a recommendation to approve the updated training. With the committee's recommendation serving as a motion, do you have any questions or comments on the updated training, members?
I actually do have a question. For pharmacists who had already done some sort of PrEP training in the past, is this going to be a requirement for licensees? I think that's a question people would probably like to know.
Anne is looking at our council.
Okay, so I feel like we looked at this before and here's what I'm going to say. We can release an FAQ or something along these lines. I think that previously it was determined that you did not need to retake the training, but I could be very wrong.
And I apologize, I don't have the answer to that off the top of my head, so we'll have to confer with staff on that.
Okay, thank you.
Thank you, Jesse. Any other member comments? Seeing none, we're ready for public comment in San Diego. Seeing none, we're ready for public comment in WebEx.
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. And our first request comes from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone. All right, Stephen Gray, we're going to try again. We're sending you a request to unmute your microphone.
Got it. Thank you. Yeah, just a comment about a recent update that some pharmacists may not have seen if they don't watch CMS publications. CMS, of course, which has jurisdiction over Medicare Part D, D as in David for seniors, has recently issued a final rule that PrEP will be moved from the PrEP medication provision and services will be removed from the Medicare Part D scheme of benefits over to the Medicare Part B scheme of benefits. Now, the problem, of course, that exists is that pharmacists do not qualify under federal Medicare Part B as in boy, and also that medications that are provided to those seniors that have Medicare will have to be billed through the medical benefit, not through the PBM and the drug benefit. So that's something that we were very disappointed to hear. May make it more difficult for some seniors to obtain their drugs and make it confusing for everyone. But if you're not aware of that, or you know pharmacists that are providing that service that are not aware of that, I suggest they check in on that because very few pharmacies are proficient in knowing how to bill under the medical benefit. Thank you.
Thank you for the comments, Dr. Gray.
Next, we're going to hear from Maria Lopez, followed by Richard Dang. Hold on. Maria, your hand just disappeared. If you still want to speak, put it back up. All right. We're sending you a request to unmute your microphone.
Just to Steve Gray.
Maria, are you still with us?
A transition and to make sure that pharmacists
Maria?
have.
If you would start over, please, that'd be greatly appreciated.
Oh, I just wanted to answer, to add further to Steve Gray's comment. CMS took a very long time to review this and had lots of public comment. They are working on a transition for pharmacies to help pharmacies who don't bill for Part B, but many pharmacies do bill for Part B because they bill for diabetic requirement. I do have a question. I brought this up prior. Just wanted to ask publicly if the board had plans to expand training beyond the Board of Pharmacy training and California specific training to larger national training programs, such as those developed by the CDC, which is supporting HIV PrEP and PEP, as well as HHS. And the American Pharmacists Association, which has recently launched this year a national HIV prevention certificate program that is similar to the the immunization certification program. It's a full certificate, several days of training online.
Thank you for the comments, Dr. Lopez.
Thank you.
Next, we're going to hear from Richard Dang, potentially our last one for this comment period.
Hi, Richard Dang, on behalf of the California Pharmacists Association. Regarding Jesse's questions, just to confirm, there are no legal or regulatory requirements for ongoing continuing education for the HIV state protocol. Their only requirement is for the initial training, and that is found in the Board of Pharmacy's CE FAQs that are posted on the website currently. However, under standard of care, it may be considered the best practice for pharmacists to be regularly completing CE on topics in which they are engaged with, especially in situations where there are new drugs or new guidelines, such as the example for why the board has updated your HIV training. Thank you.
Thank you for the comments, Dr. Dang.
And that was indeed our last comment for this period.
Thank you, David. With a motion and public comment, do we have any comments from members before we go for a vote? Jesse? Oh, go ahead, Nicole.
Sorry, trying to jump in. I totally agree with the training. I just wanted to expand a little bit on what Stephen Gray was saying and some of the other commenters about CMS and the change to Part B. And as a pharmacy that is trying to get set up to do this, it is extraordinarily difficult. And though a lot of pharmacies were already able to bill Part B, we've never billed Part B for tablets. Usually Part B billing is for services, and the way they're doing it is treating PrEP as a service, but there is a drug. So it's a very, very confusing and new process. So did just want to say that that is a barrier. And this topic could fit into several different areas, so I apologize. I wasn't sure where the best place to bring it up is, but since we're talking about PrEP right now, I also want to highlight that we're running into a problem with PBMs. PBMs are taking back money after the fact if you open a bottle of HIV medications, and PEP, post-exposure prophylaxis, is a 28-day treatment. Does not come in 28-day bottles, so you must open a bottle. So what we're starting to see is people getting delayed in getting access to PrEP because pharmacies are refusing to open a bottle because they're afraid of getting the money taken back on audit. And this has been a huge problem. I don't know how to solve it, but since we didn't get the PBM bill past 966, I do think that this is just one of many such examples. There's got to be a place that we can touch on PBMs creating access issues, but I think PEP is a great example because it's very time sensitive, and I have routinely seen people run out of time or almost run out of time on their PEP because of this exact reasoning of the PBMs. So Sorry to derail us, but I just wanted to
No,
make sure I
thank
made
you.
those
That's not
comments.
not derailing at all. That is a great point, and I think that you might want to just bring that up again during our sunset discussion as well, Nicole.
Yeah, that's what I was thinking, but since we
Seeing,
were talking about PEP, I wanted to ask now.
yeah, no, that's great. Seeing what we can maybe do with that issue, and if you can provide more of what justification they're using to recuperate the reimbursement. I'm guessing it's unbreakable package thing with the manufacturer's recommendation and but all that stuff. But
Yeah, I was just
seeing-
going to add to that too. From my experience, it's the packaging that actually says that you have to dispense it in the original container. So typically what we would do at our pharmacy, unfortunately, means the patient will have excess medication, but we'll typically call the doctor's office to see if they can change the quantity to 30. That way they have something rather than nothing. Of course, they'll have some leftover pills, but
Yeah. And then, but if it's a Friday night and the doctor's office closed, there's all those issues. A lot of the times we see it from emergency rooms where it's like
Right.
impossible to get a hold of someone to make the change. And yeah, same issue. Do we want to be sending out extra pills into the world for people to have? So
Thank you, Nicole. Yeah, absolutely. Especially since PEP requires very, very fast starting as soon as possible. So thank you for that comment, Nicole. Any other comments, members? I'm seeing none, so we're ready for vote. Jesse, how do you vote?
yes.
Thank you, Jesse. Renee?
Yes.
Thank you, Jeff.
Yes.
Thank you, Jeff. KK?
Yes.
Thank you, KKJ.
Yes.
Thank you, Jay. Satinder?
Yes.
Thank you, Satinder and Maria.
Yes.
Thank you, Maria. Nicole?
yes.
Thank you, Nicole. And I vote yes, the motion passes. All right, next agenda item was 3, but we went over that first item. So we're next now moving on to agenda item 4 or D for presentation on changes to pharmacy application process. As you are aware, we continue to struggle to meet some performance measures established for some licensing programs. We have discussed this issue several times. Processing times are impacted by a number of factors, including resources available, use of outdated consumer system, as well as in part applications that are submitted without the required information. During our meeting, we received a brief presentation on draft changes to the community pharmacy application process. I would like to thank licensing staff and council for undertaking review of the application process and working to provide applicants with additional information to understand the requirements. With variances in requirements based on ownership types, I believe the various charts illustrating the various types of ownership and supporting documents are very helpful. As part of the public comment, we also received additional recommendations. Attachment 4 includes the updated application instructions, applications, and supplemental information, all intended to assist licensees with a better understanding of the application process. As indicated in the meeting materials, public comments suggested that the board requests too much information and suggested that there was no real difference between the processing time for temporary and permanent licensure. I really appreciate that staff followed up on that information and have provided some data on processing times for temporary and permanent licensure. I would again like to thank individuals that provided constructive suggestions both during the meeting and after the meeting. No action is required by the board. I look forward to this information being finalized and hope to see improvement in application processing times and deficient applications over the coming year. Members, do you have any questions or comments? Seeing none, we're ready for public comment in San Diego. Seeing none, we're ready for public comment in WebEx.
We are open for public comment on 8D as in Delta. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand. We will call on people in the order we have requests. We're going to take a few seconds now to see if we have a request for public comment. Looks like we have a request from Stephen Gray. Hold on just a moment. We're going to send you a request to unmute your microphone.
Got it. Thank you very much. I just wanted to point out that at the meeting, there was a suggestion
from a couple of commenters that this is very, very good and very, very helpful and should go a long way to facilitating the process on both ends. And but a comment was made that similar materials should be prepared for the application for pharmacies from a nonprofit organization. There are significant differences, and I think that a lot of the people that get involved are not aware of the differences and perhaps are giving some advice that is both frustrating to the board and frustrating to the applicants. So I heard that from staff at the meeting that they would be willing to work with some folks and to help develop materials to facilitate the application for nonprofit organizations that open up pharmacies. Thank you.
Thank you for the comments, Dr. Gray.
And that was our only request via WebEx.
Thank you. Ready to move on to the next agenda item. E, discussion and consideration of proposed changes to application questions for individual licensees. The meeting materials include background on this next agenda item that stems from the federal Lorna Breen Healthcare Provider Protection Act, which seeks to address mental health challenges faced by healthcare professionals. As I shared during the committee meeting, I had the opportunity to learn about this act and the Wellbeing First Champion Challenge during the annual meeting of the National Association of Boards of Pharmacy earlier this year. Applaud the goal of reducing stigma, enhancing support systems, and ultimately improving the well-being of healthcare workers. During our meeting, members had an opportunity to review the recommendations offered by staff. We believe the approach offered is appropriate. If we reach a similar conclusion today, staff will confirm that the proposed changes would comply with the best practices and develop an implementation plan. As indicated in the meeting materials, given that the pharmacy technician application is incorporated by reference in regulation, we'll need to update the pharmacy technician application via the rulemaking process. All other applications can be updated and implemented more quickly. Members, do you have any questions or comments? Seeing none, we're ready for public comment in San Diego. Seeing none, we're ready for public comment in WebEx.
We are open for public comment on Echo. E is in Echo. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, please. Thank you. All right, members, unless there are any final thoughts, I will monitor implementation with staff and will schedule public discussion on the proposed changes to the pharmacy technician application when appropriate to begin the rulemaking process. Next agenda item is open discussion on payer practices that negatively impact patient care. You may recall we identified payer practices that negatively impact patient care as a potential issue to raise as part of our sunset report. During the licensing committee meeting, we discussed this issue. As we'll be discussing this issue also as part of the board's discussion on the next agenda item, I'm not sure we need to go into too much depth right now, but the meeting materials note that during the committee meeting, we discussed some of the concerns with pharmacy benefit manager practices. As part of the next agenda item, we'll be considering some potential statutory provisions that the board could consider, and also want to note that the licensing committee meeting, written comments were received specifically related to the issue that we will be considering as part of our discussion of agenda item 9, I believe from CPHA. Members, do you have any questions or comments? Seeing none, we're ready for public comment in San Diego. Seeing none, we're ready for public comment in WebEx.
We are open for public comment on 8F as in Foxtrot. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand. And as a reminder to all mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand. Our first request comes from Susan Bonilla. Hold on just a moment. We're sending you a request to unmute your microphone.
From CPHA. Thank you so much for including this comment, and I won't go on at length as it will be touched upon in the next item. I did want to mention, just in a connection with the implementation of SB 317, private plan payer obligations, pay parity for clinical services, that as we are working and happy to be working on this implementation, there are some issues around compliance with the health plans. And I just wanted to mention that to the board, that this might be an area of interest that could help with implementation if we were to have some idea of what kind of compliance are the plans planning to actually make action on, and when will that action be? So perhaps a survey of some kind could help us with this implementation and encourage the plans to actually take the action that we need to see payment become a reality. Thank you so much, and appreciate your time and attention to this matter.
Thank you for the comment, Susan.
Next, we're going to hear from Parth Parikh. Hold on just a moment. We're sending you a request to unmute your microphone.
I am a pharmacy owner out in Los Angeles area, and adding to what Susan was mentioning, there are many of the pharmacists who are very interested in providing clinical services, but because of payers not paying for the services, a lot of pharmacists has decided to be on a sideline and wait until there is any sort of payment model before pharmacists would invest their time and energy. So I just want to bring that to attention, that it is lack of payment is hindering the progress of that bill.
Thank you for the comments.
And that was our last request on this item.
Thank you, David. Okay, members. Next is discussion and consideration of licensing statistics. Attachment 5 includes licensing statistics for the first quarter of the fiscal year. The board has issued 3,128 permanent licenses and 470 temporary licenses during this time period, and processed 593 pharmacist exam applications. 696 pharmacist licenses were issued. Congratulations to all those individuals who received a license during this period. I would also like to draw your attention to the processing times for individual licenses, which as of October 4th, it's a very loud ringtone over there, 2024, with the exception of the designated representative applications, are all below the 30-day performance target for processing new applications. I note that the site application processing times remain beyond our 30-day processing times. We continue to struggle with staff vacancies in our licensing unit. As I stated earlier, I'm hopeful that changes to the pharmacy application and instructions will ultimately result in improved application processing times and the number of deficient applications is reduced. As a committee, we continue to monitor the progress made by staff and will continue to monitor this information to the board. Members, do you have any questions or comments on the licensing statistics? Seeing none, we are ready for public comment in San Diego.
Thank you, Mark Johnston.
Go ahead, Mark. Yeah, there you go.
Put a screen. Okay.
Thank you, Mark Johnston with CVS Health. The licensing committee report indicates that the board has inspected 79% of in-state pharmacies in the past 4 years, which is a policy goal only, not a mandate. Later in the meeting, the board will consider a statutory non-resident inspection requirement of every 4 years that will trump a policy goal. A logical conclusion is that the in-state pharmacy inspection rate will decrease even more as you redirect resources out of state to meet the statutory requirement. What is more impactful to public safety in California? Is it inspecting your in-state pharmacies or re-inspecting non-residents who have been inspected by their home state pharmacy and likely NABP and likely have achieved URAC accreditation? Most other states inspect annually and rely on you to inspect California pharmacies that hold non-resident licenses in their state. I suggest the striking of the draft 4-year statutory requirement, changing it to a policy goal, as with in-state pharmacies. giving the board the autonomy and flexibility to decide where to utilize your resources in the future and not be bound by a statutory requirement that forces you to spend your resources in a certain way.
Thank you for the comments, Mark. Any other comment in San Diego? Seeing none, ready for WebEx. David?
We
David?
have,
Thank you. Oh,
my apologies. It helps if I unmute myself. We had a hand up. We're going to ask that that person put their hand up again if they wish to speak. So for everyone, now is the time to raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand. We will call on people in the order we have requests. As a reminder to our mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request online, I think we're ready to continue.
thank you, sir. All right, we're ready for next agenda item 9, discussion and consideration of issues to raise as part of the Sunset Report. As we approach the deadline to submit our Sunset Report, as a board, we have completed significant work to identify areas to raise as part of the board's report to the legislature. I believe the work we have undertaken is very notable. I'm very proud of our efforts and proud to serve on this board. As we begin our discussion of the draft document presenting the new issues, I want to remind members that the board has already approved many of these items. We need to be respectful of those items where the board has already taken actions. Further, this is not the appropriate time to provide edits to the language of the report. We cannot wordsmith everything, especially the proposed statutory text. The ultimate language included in any legislation will be that of the legislature. I'd like to ask members that have identified non-substantive issues, grammar, etc., to email Anne directly following the meeting. From a process standpoint, I intended to provide each member with an opportunity to provide comments on all of the items. Following this process, I will solicit feedback from members and will entertain a motion. Once a motion is on the floor, we'll open for public comment. I also want to note that we received a significant number of written comments related to this agenda item. The draft includes 22 new issues for inclusion in the board's legislative report, and draft statutory language were indicated. As previously stated, a number of these have already been approved, which includes about non-resident pharmacies, pharmacist to pharmacy technician ratio, pharmacy technicians compounding outside of a pharmacy, IV hydration clinics, standard of care practice model for pharmacists, remote processing, records, hormonal contraception, ownership prohibition, retired licenses, and changes to pharmacy technician training. In many of these instances, the board has already approved the language to be offered as part of the legislative report. However, in others, the language has not been approved. As an example, the board has already agreed that a change to the regulation of pharmacists and a transition to a standard of care pharmacist model is appropriate. The board's conclusion was memorialized in the board's report to the legislature. Since that time, the licensing committee has worked to develop the draft statutory language, which was approved near unanimously by the licensing committee during its September 2024 meeting. With that background, now I'm going to call each members to provide their comments on the draft report, and where the board has not already reached a conclusion or recommendation, your thoughts on the draft and proposal. I will start in the order that usually I call for vote. Jesse, it's okay if we're here till 9 p.m., so go take your time.
Okay, so just to be clear, we're going through all of the items at once. Is that right?
Well, I mean, as a discussion
gonna go
evolves,
one
I'm
by
sure we can come back to talk about things together, some
Okay.
consensus. Yeah.
Well, yeah, I was going to say,
You have a lot.
I'm sure I will think of something later. The biggest notes that I have will be for the standard of care piece, which I know is going a little bit out of order, but I wanted to really highlight the efforts of the board, taking years of effort to create a med error reduction committee, doing a standard of care committee. And I just wanted to highlight how much of the focus was in a retail chain setting. We still have burnout, and there's still pharmacist wellness that needs to be addressed and is still ongoing. And at the committee meeting, I did want to make sure that this is kept at the forefront, because most of our pharmacies are community chain pharmacies, and we really need to get perspective from the retail chain pharmacists to see what they're able to take on. There is language in the law today, and there's language in the proposal that a pharmacist has the ability to decline services, but that's just not the reality of what we're living. And now that I'm hopefully on the tail end of flu season this year, and this is the first year that AB 1286 has been in effect, I can tell you that it's still stressful, and I don't really have the autonomy. So just to kind of give some of my own examples and experience, I mentioned at the committee meeting that my closing technician is on a leave of absence, which they still are. I'm generally the closing pharmacist, and so most of the time, all I have is a front-end cashier who's cross-trained in the pharmacy to help me. There have been multiple times when there's no one available or where they don't really fully know what they're doing. I have made multiple requests to shut off the vaccine appointments system once my technician leaves, and those requests have been ignored. And I know that several of my colleagues have gone through the same thing. I'm the point of contact essentially for most of the pharmacists across chains, so Rite Aid, CVS, Albertsons, Vons, Pavilions, and Ralph's. If they have any issues, I'm that point of contact in the pharmacist that they asked for advice and that they air their grievances for. I've had 8 vaccine appointments at one time. And you just think of it from the perspective of a consumer, right? You get a text message or you see a sign that says that walk-ins are welcome for any clinical service. So we'll just use vaccine as the example for now. You're assuming that you can walk into that pharmacy and get it. Now, maybe it's a little busy and they ask you to make an appointment. You then assume that if you have an appointment, that is enough and that should be sufficient. And so if I have someone walking into my pharmacy and I don't have the capacity, or say there's a staffing issue, I should be able to decline it, but I'm the person who ends up being frustrated and getting the brunt of the consumer's frustration, understandably so, because if they make an appointment, they should be able to get that service. And until pharmacists have the autonomy over every aspect of that, including the scheduling, including the advertising, this is just going to create pressure on pharmacists who are scared of turning people away. So I've heard from a lot of floater pharmacists that they're afraid of turning away walk-ins because they're afraid that they'll be scheduled further away from where they live. And these are real consequences that our pharmacists in chain settings are experiencing across different settings. Let me see some of my other notes, because the autonomy was the big piece, and as well as the staffing. And I do want to highlight that the AB 1286 addressed a minimum staffing for pharmacists who work alone, like myself, but it doesn't address the understaffing for pharmacists who work at large volume pharmacies. So I've heard of pharmacists who are still doing over 300 prescriptions a day by themselves, 12-hour shifts with over 60 vaccine appointments. I mean, that it's nearly impossible to do things adequately. And on top of that, with a quota ban, companies have become creative on how they want to get around that, but still encourage people to do the most vaccines or prescriptions. So some of the examples that people have presented to me are getting phone calls or being called out on conference calls asking why they aren't performing a certain vaccine or why they did 0 vaccines one day. I was working alone trying to balance all of the appointments that I had when I got a call asking why I wasn't doing RSV in the middle of flu season. And I was very frank in saying that my focus right now is making sure that I get the right vaccine in the right patient, because I have 8 vaccines going on right now. So you have baskets all over the place. Let me see. The other thing that I wanted to highlight too, because a lot of the comments that we've received in support of standard of care, which I greatly appreciate, are from people who do have generally a financial incentive in this. The people who don't seek to gain anything financially are retail chain pharmacists. We don't get any additional compensation, but there is a lot of money to be made off of expanding pharmacist duties. And unfortunately, because we don't have any PBM reform, that means that pharmacies have to get creative with the services they provide. And I do want to expand services as much as possible, but I want to make sure that we're doing this intentionally and that we're doing it safely and not overwhelming our pharmacists who are already spread thin and fearful of retaliation, fearful of their jobs. I have had a few pharmacists submit comments to me. I'm just going to read a couple of them because the reality is a lot of the retail chain pharmacies are working right now in the middle of flu season. And so they can't sit on a phone call for hours to call in, and maybe they can submit written comment, but then their name is public information and they may not want their employer to know. So the only way they can remain anonymous is by coming onto this call. So one pharmacist told me that the main problem with continuously expanding pharmacist roles is we never or rarely get any additional compensation for this work, and we rarely get any additional help to do this, while piling on too many additional responsibilities on top of our core work without any additional help will lead to burnout and medication errors. Expanding pharmacist duties can seem as beneficial, especially in a clinical or hospital setting. Expanding it in retail will just cause retail overloads to further overwork us with zero additional help or compensation. How do we give endless vaccines, HIV testing, specialty injections? Some stores even have blood pressure and cholesterol testing, just to name a few of our top core duties. A few things of suggestion: a minimum of 2 additional technicians or 1 additional pharmacist for specialty clinic type stuff like HIV testing with require expensive time away from the counter, basically like a doctor's appointment. And then another pharmacist said it should be the sole discretion of the practitioner as to whether they engage in these services. It should not be something that retail chains mandate their employers receive minimal or insufficient training on, and then have an inordinate number of additional responsibilities added on to as a condition of continued employment. And I need to emphasize that this is something that our employers do require of us, or they pressure us into. And after going through this flu season with no technician and with no pharmacist overlap, and I will say my pharmacist overlap was taken away to in order to cover off-site flu clinics, it's too much. And I appreciate that there needs to be a movement in direction. I think there needs to be a discussion on how we do it. But in a retail chain pharmacy, it's just not possible to do it safely without addressing the staffing and the lack of autonomy. I'm going to leave it at there for now, but I'm sure I will have notes on other items once they come up.
Thanks, Jessie. Thanks for the comments. We'll go to Renee next.
Hello. I just wanted to mostly just agree with, I guess. I mean, are we just kind of saying what so I appreciate that we're doing. So I think it's number 3. Let me just get it on here. Talking about the topic pharmacy technicians compounding outside of a pharmacy. So I do think there's a lot of concern, and we did get technicians calling in, who were concerned with the practice and also not having a pharmacist. So I really do appreciate that we're going to be working on that some more with the statutory proposal, which is in there. And then the other one is the IV hydration clinics. And I think that that's really important, and I appreciate what's already been done, the education that was developed and has been already sent out and was co-branded with some other DCA programs. at least to kind of get some kind of notification to people to understand that they're compounding in these IV hydration clinics. We'll have attachment 6 has the statutory change, and then also that there'll be a self-assessment form, because I do think that there's just a lack of information. So the self-assessment form is always helpful for people to really understand what it is they need to do and to meet and see where their gaps are. So I think those are going to be great things to keep on there.
Thank you, Renee. Next, Jeff.
As a new public member, just trying to learn all of this information that's coming out regarding this annual process for the Sunset Report. It's like drinking out of a fire hose. I appreciate the hard work. I don't have anything to add at this time. I'm just trying to learn.
Thanks, Jeff. Thankfully, not annual. It's just like every 4 to 5 years. So thank goodness. Yes. If it's annual, I think Anne's gonna have a heart attack. So I don't think that would be healthy for us. Next, we're gonna go to KK.
The only comment I have is for the use of AI. First of all, thank you for keeping the door open for the innovation. I think the language, at least in this paragraph, is suitable for some mundane tasks to be automated, like order entry, especially taking the feed from the electronic orders. I think that is something, not taking away anything from the pharmacist as far as, plus it makes pharmacists more available for the patients and available to do more value work, having more face time with the patient. So I think that things facilitate. Having said that, I'm in complete agreement in AIs or algorithms doing the counseling part or even doing the access part, especially in the cases where access to narcotics or something where clinical judgment would have needed. So pretty positive response to that comment.
Thank you, KK. How are you feeling about overall concept about the statutory proposal that we have? Seems
for all the 10 points or just for the AI?
Just the everything, anything and everything. But I guess
I mean, I like the format. I mean, there's plenty of things I can say, but most of the comments that I have put myself here is in support of what is there. So I don't want to take the board's time for that.
Perfect.
Especially, second thing I have a little bit of, concern or I'm happy about is pharmacy technicians' role, clarification that they should be working under pharmacy supervision only and not any other practitioner supervision, because that's just going against the definition. But again, I'm in support, so I don't want to put some time on it.
Awesome. Thank you, KK. And next we have Jay.
Primarily, I'm just thankful for a lot of the comments that we got with regard to standard of care. For me as a public member, it's difficult to tell which ones come from people who stand just to get a lot of money versus people who are actually looking out for the public. So I appreciate having you guys to actually bounce that off of and think through. And I do think there are some things that need to be worked out. Overall, I like the document. I agree with KK with regard to artificial intelligence. It is here, period. And we've got to figure out how to utilize it for the best, to get a best practice where AI is concerned. And I think we've started down that road. And again, I think my other one that I really thought was useful was the hydration, giving information to the public as well as to the pharmacists about hydration, that it is compounding, that there are risks, that what the risks specifically are. And I appreciate that was actually incorporated. And that's it I do have some concerns. I don't know about the wording yet, but with pharmacy delivery services, including DoorDash, Uber, things like that, that one I feel like we could spend a little time on, but overall, things good.
Okay, sounds good, Jay. Next we have Satinder.
So overall, I'm in favor, right? First of all, but I do agree with some of the comments that the KK made, and also from Jessica too. Concern about the overwhelming the staff, that should be not discounted. That's real. At the same time, I feel that we've been trying so hard to make sure that our pharmacists, and now that we're requiring more education about our technicians, that they're working at the top of their education is real, but we need to figure out how to do it. And I like some of the proposals that are being proposed, increasing tech ratio, artificial intelligence, and and central fill, that we talked about as a part of that technician ratios as well. Those will allow our pharmacists to be free, and we need to give more tools instead of restricting what the pharmacist can do or those kind of things. We should be finding ways to expand it, and I think this is going in the right directions.
Thank you, KK. I'm sorry, Satinder. Anything else to add on? I'm sure we'll have more
Yes.
to talk. Yes, KK.
If you don't mind, can I add something?
Absolutely.
Just to add or support to Ms. Crawley's comments earlier about availability of staff or having some say in the scheduling. And this is over the years, in my personal experience as a business leader, as well as consultant. And I have seen this, that there may be a root cause here that causes the consistent, real or perceived shortage of help for the pharmacist. And it may have been rooted in what pharmacy is getting paid for the services. So I think when we look at the other topics that we have, the PBMs and clinical judgment being challenged and whatnot, but maybe some of the root causes for not having adequate help may stem from kind of a work pharmacists do and kind of a compensation they receive for those services. Could be a 5-minute or a 10-minute counseling at a pharmacy counter, could be life-saving for somebody. But is pharmacist getting paid for that particularly? And what does that do to, if pharmacists take care of that counseling, what happens to the workflow behind that? Is pharmacist encouraged or provided an environment where they can take the time it takes to do that counseling? Or counseling is just one aspect I'm talking about, right? That could be an IV pharmacist working in a hood, trying to do 100 IVs in a day or 60 IVs in a day, whatever that is. So I think the root cause maybe lies with the compensation part, what pharmacy is receiving as a part of their services.
Thank you, KK. All right, next is Maria.
Yes, thank you for the opportunity. I'm pleased to see a list of all the things that we have worked on and discussed and opportunities coming up. And for the sake of time, I only want to talk about 2 areas. One is number 12, establishment of self-assessment process and statute. That's, I think, a very important item for licensees and for the board. It seems like, not necessarily something that is, in lights kind of thing, but, all of us know that that have filled out a self-assessment, how wonderful the tool is to allow us to self-critique and to improve. And summarizing the statutes to make the process more streamlined, I think is something that the board could certainly work on. One self-assessment is a little bit more streamlined and the others require a lot of time and effort and process to make even a minor change, that it could take, and regulations and laws are changing so quickly that it could still take over 2 years before the self-assessment catches up with where the regulations are. And it also is very confusing to licensees and to the board. I don't know if you remember, we had one self-assessment that was still in the process of being approved for change when new changes came in. And so it was, it had not been approved, the prior version had not been approved, and we were making changes to the changes to the changes. And that was one of those that take, I think was at least over 2 years. I hope it's already gone through it. It's not the one that's still pending, I hope. The other is about 13 AB 1286 clarification. I'm looking forward to having more discussion on that. I know that we've had in several meetings and several different concepts, the idea of corrections that need to be made to the statute regarding the training or required training that's for the authorized technicians. And I really like the information that's in the attachment here that shows the proposed language to separate out so that those pharmacy technicians that are not involved with immunizations could do the other functions and not be required to be trained for immunizations, even though that's not part. I think that was an unintended consequence, which is kind of, hopefully, you would think would be an easy fix. But it also caused a little bit of discussion about the C, which is initiate, receive prescriptions. And the discussion about initiate transfers. And I'm looking forward to more discussion because we heard public comment, a couple of things on that. One was public comment that technicians should only be receiving and not initiating because of concerns of diversion. I found that an interesting concept and would like to learn more about that. There was also I don't see anything in here, which may be another oversight or maybe just me not understanding what the regulation says, but it'd be nice for the originating pharmacy having a pharmacy technician being able to send the information. So as the requesting pharmacy, the technician can potentially initiate and receive, but it's okay to talk to another technician at the other pharmacy, the originating pharmacy, and that seems to be kind of a gap that's not mentioned in there. Lastly, I've heard public comment, and and I personally have not researched this, but I heard public comment that that transfers, according to the DEA, for controlled substances can only be done by a pharmacist. So this initiating, receiving, sending, transfer prescriptions between pharmacy by pharmacy technicians appear to be for non-controlled substances only, which if this is true, I would certainly want to be discussing that a lot more because that would certainly be an area that could be potentially confusing. But thank you for the time. I am looking forward to working in these areas.
Thank you, Maria. And the next is Nicole.
Thank you. I'm going to try to limit my comments to the things I think that I have like expertise in, to not be too duplicative. But what I wanted to bring up was the issue of delivery services. A couple things I wanted to flag. Yes, totally think we need to have some rules and some regulations about them, help protect the public, but I wanted to flag for everyone, this is a huge issue for people who are chronically ill and disabled. So we need to be very careful that we do not create access issues. There's a lot of people who can only get their medications delivered. I actually have to rely on medication delivery because when I got sick, I lost the ability to drive. So getting those medications delivered is most of the time the only way that I have access unless I get someone to help me go get it, which is hard when you need to rely on somebody else. And still doesn't help you necessarily with the issue of doing a consultation. So I think we need to focus on creative ways to do the consultation for people who can't be in person. I also want to flag this issue, not to make anything political, the day after the election, but I kind of have to assume that going forward, access to transgender medicine is going to be reduced. And so we need to preserve access to delivery services so that people can still have access, even if it's not available in their immediate area. The next one I wanted to talk about was payer activities. I already touched on this. I won't repeat the whole thing, but we are running into issues with the PBMs creating barriers to access for PrEP because of taking back the money if you open the bottle. Yes, it is based on the package saying that, you should dispense in the original container, but if you reach out to the manufacturer, they will provide data to you about how long you can have the drug out of the bottle and how long it's safe to keep that open, which sometimes is up to about a year. So it's absolutely fine to open it and dispense for PEP, which is, again, a 28-day supply. So that's very concerning. And just so people know, PEP, depends on your regimen, but several $1,000s per regimen. So to have them, and they always take it back after the fact, which is seems very intentional. They let you give it out. They tell you there's a paid claim and then come back and take it on audit for these huge, huge amounts of money. So that concern is very, very concerning to me. And I've actually seen it impact the way pharmacies provide PrEP. And, this is Los Angeles. This should be one of the easiest places to get PEP. And yet we're seeing people run into barriers because of this. The next one I want to flag is the self-assessment. I know this was not the intention of this point, but I did want to bring up clinic pharmacies. So there are a lot of clinics in California where, there's a clinic providing medical services and there is a pharmacy owned by the same company within the same building. And they are licensed as retail pharmacies. But because they have that relationship with the clinic, they function almost somewhere in between a hospital and a retail. There's some things that apply to retail that just don't make sense in a clinic pharmacy, and some things that do. So I wanted to encourage us to look at maybe considering a self-assessment specifically for this type of pharmacy, or resources for them. There are thousands in the state of California, and yet they aren't, not all of them have pharmacies, of course, but having that, a lot more of them are actually opening pharmacies now because of some changes that are happening on the national level with our funding. I won't explain that whole thing, but if you have questions, I can walk you through it later. So I think it would be really helpful for them, especially as we're seeing so many new ones, to have that guidance of how, which rules you have to follow and how do you apply certain things that maybe apply much more strictly to retail that you're not really going to see in a clinic. Last one, going slightly backwards, is standard of care. But I'm talking about this one after self-assessment because I also wanted to bring up clinics, and that having a standard of care model makes a ton of sense for these clinic pharmacies, because we do work with the providers and often can take some of those functions off of them under like collaborative practice agreements, things like that. So that standard of care model makes a lot of sense. And I totally understand the concerns in the more traditional, strictly retail outpatient. So I think there needs to be space to have, I don't know if it's different rules for different settings, or if it just falls under the, at the discretion of the pharmacist, that sort of thing. But I don't want us to sacrifice one area for the sake of the other in either direction. So I want to make sure we can protect, our retail colleagues, but that we don't stop the progress. And again, there's a shortage of medical doctors, of providers, and this is a great place where pharmacists can fill in some of those gaps. Annual wellness visits, they're great for PEP and PrEP visits. There's just so many things that the pharmacist can provide that make a ton of sense. So I want to make sure we don't limit that and therefore decrease access to everyone in California. All right, that's it for me. Thank you.
Thank you, Nicole. A very helpful discussion. All right, everyone. Thank you. I know this is a lot of information. Seems like we're never shying away from bold, controversial stuff.
Can I add a couple of
Oh,
things
yeah, sure.
now
Go
that
ahead,
I've heard
Jeffrey.
everyone? I do have some comments on the AB 1286 clarification. I appreciate Maria bringing that up. I agree that I think there needs to be some clarity, because I think if they're receiving and initiating transfers, technicians should also be able to send transfers. And I think we do need clarification on the controls. It is also my understanding that it's a federal law that allows the controls to be pharmacist. The other question I had on the language, and maybe we don't even need to clarify it, so this is probably more of a council question, but in the previous language, it specified the certification for paragraph 4 of subdivision A of section 4202. In the new language, it says a certified technician as defined by section 4202. So my question, just for clarification, is if that still is specifying towards section A subdivision 4 requiring that national certification, just because in the discussion leading up to AB 1286, a huge reason for keeping that subsection was for the continuing education for these technicians, since there's no state requirement on continuing education. So I don't know if we have necessarily the answer for that.
The intent is the technician who's going to be performing all those 3 possible duties are certified.
Okay.
And that if you are just doing immunization, they just need to be then certified and trained. If you're not doing immunization, that they don't need immunization training to be able to receive clarification, or that if they're not needing to, receive transfers, so that we don't need to make those people who are just getting clarifications or getting transfers to have to be certified in immunizations. So that's the intent.
So I think, Jesse, that I think what you're asking is the reference in the proposed language, is it specific enough to grab the 4202A4? And I think we understand what the policy is, so we can work with council to make sure that if we didn't put in the exact paragraph, we can reference it.
Okay, perfect. And then just to touch on one final note for the standard of care, honestly, if there is a way where there is just more support or autonomy for retail pharmacists, so whether that's having 2 pharmacists on duty in order to perform some of those services, or whether that's also making sure that there is control over scheduling from the pharmacist on duty or from like the store level. I think there would be a path forward, because I agree there are plenty of settings in which a lot of those services are definitely appropriate and needed.
Thank you, Jesse. That's great comment. So we had quite a few discussion. I know it's a lot, so we can come back and talk about it too after hearing some public comment. So let me just, I think the standard of care obviously is a deep and very passionate issue that I chair the committee, and I think that ultimately, if we can transition to a standard of care model of specific patient care services where sufficient safeguards are in place to ensure pharmacists retain autonomy to utilize professional judgment in making patient care decisions, that's the ideal conditions. I believe the board believes that transitioning to greater use of a standard of care model in the provision of specified patient care services would definitely benefit patients by providing expanded and timely access to patient care for suitably educated, trained, and experienced healthcare providers. And so I highlight that because I believe legislative proposals specifically related to standard of care include some significant guardrails and protections. I think that we're trying to make it, to Jess's point, I think this is an opportunity. I think there's an opportunity for us to really put forth a proposal that streamlines authorities that already exist and create provisions for some new authorities. The proposal does not create mandates. I just really want to emphasize this proposal does not create mandates. And I think if anything, it's contrary to the mandate. The proposal clearly lays out pharmacists' option to decline based on the idea of standard of care, which I believe this will be a powerful tool even for current pharmacists performing these functions already. Also, the proposal includes explicit language that pharmacists cannot provide services where they lack sufficient education, training, or experience, or where the pharmacist staffing of the pharmacy is insufficient to facilitate comprehensive patient care services. In this language, proposed standard of care specifically lays out setting as a requirement for pharmacists' ability to practice. And also it lays out that nothing in this section shall be construed as establishing an obligation of a pharmacist to perform or provide a service or function authorized by the subdivision A, where the pharmacist has made a professional determination that, one, they lack sufficient education, training, or expertise, or access to sufficient patient medical information to perform such services or function properly or safely, or to performing or providing such service or function would place the patient at risk, or where pharmacist staffing at the pharmacy is insufficient to facilitate comprehensive patient care. I understand this is an issue that may raise some concerns that are truly understandable, but I would like to remind everyone that we've come a long way. I still look back at the days of 2020 when I first got appointed to this board. The pandemic was in full force and everyone was living in a deep uncertainty and fear. This board back then and still now, I believe, acknowledges such importance of how to bring consumer protection in many ways that we think would be truly beneficial for millions of Californians. California enacted nationally leading consumer protection in many ways by supporting and often advocating for such things, and quota bills, increased in fine authorities, and remarkably, we passed in AB 1286 that truly looked at the intersectionality of medication error with staffing. That is the most forward-looking in any parts of the entire United States of America. I think AB 1286 understandably is in early stages, but I truly believe this reform will bring the most safe and highest quality pharmaceutical care to California patients. And ultimately, I know change sounds sometimes daunting in theory, but I feel strongly hopeful in finding common ground. And I think finding harmony and finding a path forward to look at the future. And I think this is for the future of Californians that will truly benefit Californians' patient care. I believe this can help improve health of millions of Californians in ways that has never been done. So I know this is complicated, controversial, but I do believe this is the right thing to do. I believe this is the right thing for California patients. So I know I talk a lot, so I will give some members opportunity to comment, of course, after, but I just do think that it is appropriate. I feel strongly where I do want to make a motion myself to approve this new issues and draft statutory language not previously approved by the board as consistent with the board's policy discussions, and further to delegate to the president and to executive officer to finalize this portion of the sunset review with staff for inclusion in the board's legislative report. With that serving as a motion, I'm looking for anyone to second my motion, and so we can hopefully begin public comment. Members?
I'll second that.
Oh, thanks. Thanks, Jeff. Falling on deaf ears after I pour my motion out here. Anyway, I know that there's a long ways to go, but I think that this is a good opportunity for us to continue this discussion. And with that, we're ready for public comment in person in San Diego.
Keith Yoshizuka, California Society of Health System Pharmacists. We emphatically support the idea of migrating to a standard of care model for pharmacists. We also applaud the board's position to take a bifurcated hybrid model, looking at standard of care for pharmacists' activities, but maintaining a more prescriptive model for regulation of pharmacies per se. We ask that you possibly in your sunset review follow up on a statement made to the legislature in your report that in order to fully develop the pharmacist provided patient care, that must be associated with some sort of reimbursement. Now, CPHA's AB 317 opened the door and it went a long way, and I'd like to see it go full circle and include those pharmacists that are providing services not within the four walls of the pharmacy. Lastly, President O, regarding your last comments about not being an obligation, and I think part of it is that Pharmacists are going to have to get used to saying something they're not used to saying. Yeah, they're going to have to get used to saying, I'm sorry, I'm not qualified to provide that service. It feels uncomfortable, but physicians do it all the time. When a gynecologist, it would never happen, but if a gynecologist was asked to perform thoracic surgery, what is he going to say? He's going to say, I'm sorry, I'm not qualified to perform that procedure. And pharmacists are going to have to get on board because they're doctors. They have to know their own limitations and they have to admit, yes, I'm not qualified to do that. So thank you very
10
much for the
seconds.
opportunity.
Thank you for the comments, Dr. Yoshisuka.
Hi there, Mark Johnston with CVS Health. 2 minutes for 111 pages. I'll attempt to streamline my comments here, and I don't have time to thank the board for each great allowance in this package. In attachment 1, non-resident PICs, you'll be roughly the 20th state, realizing this is challenging for these non-resident facilities and pharmacists, especially small non-residents. Options have been developed. NEBP has developed the UPJE exam, but California would require passing a very difficult test. Iowa and Idaho require registration only, no exam, not full-blown licensure like California would require. As currently written, I'm concerned with access to care, especially for specialty pharmacies with contracts to be the sole dispenser of a drug. If a pharmacy doesn't have 2 licensed California pharmacists, they will have to cease dispensing into the state. At a minimum, I suggest a 90-day grace period similar to in-state PIC allowances. CVSS also objects to the striking of, provided that the grounds for the action are also grounds for action in the state where the non-resident pharmacy is permanently located, as this would give California the right to require non-resident pharmacies to follow California's ratio law, as an example, which is the most restrictive in the nation. Please respect home state law and imagine if other states impose their restrictive legal provisions upon California pharmacies that hold other non-resident licenses. CVS is also opposed to the finding authority in attachment 4. Changes in attachment 15 are not ripe and need much clarification and revision. For example, there is no individual who makes changes to policies and procedures at CVS. It's a panel of experts, legal input. Ultimately, an admin types
10
impose
seconds.
changes. Is the admin the individual making the change? I'm not sure who the individual is. And I've got
Time.
pages of other comments. 2 minutes.
Thank you, Mark. Thanks for the comments.
Sean Kim from California Pharmacists Association, representing pharmacy across all practice settings. I would like to talk about 2 issues. The number 1 is the PBM. Unfair practices by PBMs are disrupting patient care by causing delays in accessing medications. These delays stem from PBMs limiting pharmacy choices and imposing a reimbursement below the cost of high-priced drugs, which hinders pharmacists from stocking essential medications. This is not only a financial issue of pharmacies, but also directly impacts patients who depend on accessible and timely care. When PBMs mandates patients to use mail order pharmacists or PBM-owned pharmacists, they disrupt the vital pharmacist-patient relationship and supports medication adherence and overall health, especially for those whom managing chronic conditions. And number 2, CPH has worked with national organizations such as NABP, NASPA, and APHA, who has extensively researching the model of standard of care. We collaborate with state associations that have successfully implemented this model alongside with their board of pharmacy. Our members strongly support adopting the standard of care, recognizing the full potential, enhanced patient care, and public safety. A defined standard of care is essential to fully realize the impact of key legislations that we have passed, such as AB 1114, Pharmacy Services, SB 339, HIV PrEP and PEP, AB 317, Pharmacist Service Coverage, which build on foundational provider status of SB 493. These laws empower pharmacists to support patients' care in preventive services, chronic disease management, public health. Without codified standard, however, these legislative achievements are only partially fulfilled. Thank you again for your attention and critical issues. The adaptation of standard care is a significant step of strengthening
My
professional role of
apologies.
public health.
Time.
Thank you.
Thank you for the comments, Dr. Kim.
Good afternoon, Lori Walmsley on behalf of Walgreens. I'll keep my comments to the things where I think some changes still need to be made. There's a lot of really great work here, but based on the time, I'll keep my comments to some potential changes. In attachment 2, it talks about allowing technicians to perform other activities outside of the pharmacy, specifically compounding. As you're contemplating that, I would ask you to consider some other additional topics, like, for example, allowing pharmacy technicians to perform immunizations under the supervision of a pharmacist outside of a pharmacy, for example, at senior homes, employer groups, those types of things. It would allow additional public access and still have security safeguards. Additionally, you're talking about remote processing in another provision. Again, if you would allow compounding to occur outside of a pharmacy, I don't know why you wouldn't allow data entry to occur outside of a pharmacy with certain safeguards in place. Around artificial intelligence, while I do support the concept that you don't want artificial intelligence to usurp the authority of the pharmacist, I do think that there needs to be some wordsmithing here, and I know that's not why we're here today, but I do think that there could be some potential impacts to things that are currently used in practice today, including the use of DUR engines to reduce things like alert fatigue and things like that. So being mindful of unintended consequences there, it might go a little bit too far. And is there a way that we can work together to wordsmith this? Around white bagging, which is attachment 9, I would encourage you to look at the language in subsection 3 that says that each prescription shall be delivered during the facility's normal business day. Well, I think that's always optimal. There are things that are outside of the pharmacy's control. So, for example, if the UPS truck breaks down and it, for some reason, arrives at the
10
hospital
seconds.
late, I don't know how the pharmacy can control that. Lastly, under the pharmacy technician scope, I would encourage you to look at expanding the type of vaccines that a pharmacy technician can perform. Thank you.
Thank you for the comments, Lori.
Hello, committee members. It is a pleasure to be here with you for a change. My name is Elle Sieber, and I'm a 30-year-old woman living with an MECFS-like presentation of long COVID here in sunny California. My comment is regarding the sunset review items on non-resident pharmacies and IV hydration clinics. From past meetings, we know Title 16, Section 1711 on quality assurance aims to supersede USP guidelines for compounding pharmacies, making California the only state to exceed federal standards. This poses serious concerns as echoed unanimously in past meetings. With respect to non-resident pharmacies, a motion that has already been approved, my concerns are only amplified. By extending California requirements to non-resident pharmacies who export preparations into California, the BOP further exceeds the bounds of their regulatory authority by proposing excessive regulations and then imposing those regulations on other states outside their jurisdiction. On top of this, the meeting materials strongly suggest additional intentions of the board to expand regulatory authority beyond 503A compounding pharmacies to IV hydration clinics, which are currently out of purview. As a long COVID patient who relied almost exclusively on IV hydration services when I was more moderately impaired, I stand in stark opposition to this expansion of regulatory authority. In medicine, an ethical consideration for prescribing drugs is a cost-benefit analysis. The cost of applying the BOP's current regulatory approach to IV hydration clinics would be devastating for me. Many of these treatments are challenging, if not impossible, to access with covered care. Without these services, I am unable to work full-time and financially provide for myself. With all due respect, please focus on doing what you do well instead of doing more and potentially harming patients like myself. Thank you.
Thank you for the comments.
Good afternoon, Nathan Painter. As an individual and also representing some of my colleagues at UC San Diego, I just want to write in support of the standard of care model and just highlight some of the features that my colleagues and I have discussed, and that's really expanding the access to evidence-based care across the state to improve safety and the health of potentially millions of Californians because of the shortages of pharmacy, shortages of healthcare doctors, and all sorts of shortages across the country. By improving this, we'll hopefully improve health disparities in marginalized communities, but certainly understand the issues of workload, and which can be working in parallel in addition to starting a standard of care model, because it definitely is an important issue. I also am faculty at the School of Pharmacy, and it is certainly one of the advocacy things that we bring up on a regular basis about advocating for improved workplace conditions, but also that often our pharmacists who are most engaged in the advocacy and professional organizations also tend to have some of the greatest work-life balance and positive work outflow who are engaged in the processes, but certainly understand that time limitations and work schedules sometimes preclude that from happening. So appreciate the time and that we implement the standard of care model so that we don't lose this opportunity that's been hanging in front of us for a number of years. So thank you.
Thank you for the comments. Sorry, I didn't catch this. Do we have anyone in San Diego? Anyone else? All right, we're ready for public comment in WebEx. And after this, we'll take a quick break just so that we can get some pizza.
We have several lined up. We're going to start with Michelle. Hold on. Michelle Pelter, we're sending you a request to unmute your microphone, followed by Jassy Graywall. Michelle, we're sending you a request now.
Hello?
Oh, Mitchell, not
Yes,
Michelle.
it's Mitchell. Thank you.
Go
I
ahead,
speak in, yes, can you hear me?
Yes, go ahead.
Yeah, I speak in favor of the proposed standard of care model as part of the sunset process. I retired from Kaiser with over 30 years of service in charge of ambulatory care as well as the residency program. Our profession is well prepared to move to a competency-based form of practice and should no longer be tied to a lowest common denominator means of treating our professionals. Furthermore, this will greatly simplify the piecemeal regulations and laws addressing various niche areas of practice, as well as the necessity of introducing new bills to allow expanded scope of practice. I might add, many clinical practice guidelines of national organizations change, but laws, of course, are a little slower in change. I continue to practice pro bono as an ambulatory care pharmacist, as well as a training site for pharmacy residents and interns, allowing us to practice at the top of our license rather than narrow bands of disease treatments greatly enhance our ability to deliver care to very, very needy working people and their families that otherwise could not afford care. I would suggest also determining a role for the advanced practice pharmacist within your new standard of care, and I thank you very much for listening.
Thank you for the comments.
All right. Next, we're going to have Jassy Graywall, followed by Vincent J. Hold on, Jassy. We're sending you a request to unmute your microphone. All right, going to try again, Jassy. Hold on just a moment.
Can you hear me?
Yes, go ahead, please.
Wonderful. Jassy Graywall with UFCW. Since we only have 2 minutes and about 22 items, I will keep my comments specifically just to standard of care. And I believe you all have our letter of concern that cites numerous data points. We did a survey of our pharmacy members, and within a couple of day turnaround, had about 150 retail members complete this survey. And some of the data that I just want to highlight really quickly before getting into my comments is that only 6% of our respondents felt that they could safely take on more patient care services in their pharmacy. 85% of pharmacists indicated they do not have sufficient time or staffing to screen before other clinical services. 66% of pharmacists said that they do not have enough time to properly screen before vaccines, and 69% believe they do not have enough staffing to do so. Of the 19% of pharmacists who said that they could take on more duties under certain circumstances, 77% indicated they would need more pharmacist overlap, and 73% indicated they would need more support hours to provide services safely. We have significant concerns with the standard of care model, not to say that it shouldn't happen, but to make sure that there are certain systems in place, including good working conditions, to be able to safely do these services for consumers before we fully jump in and take on this model. The standard of care model would be the biggest change to the profession of pharmacy in the last decade, if not decades. And we are talking about it as part of 22 different items in a sunset proposal. We would ask the board to talk about standard of care as a standalone proposal to make sure that we're actually giving it the due consideration that it deserves, and also taking into consideration the workforce survey that this board just approved as part of that
10
consideration.
seconds.
We also do not have a medication error system up in place. And so there are certain systems that aren't here that need to be in place in order to be able to do a standard of care model safely for consumers.
Thank you for the comments, Jazzy.
Next, we're going to hear from Vincent J. Charez. Hold on just a moment. We're going to send you a request to unmute your microphone.
Oh, no.
Are you with us, Vincent?
Can you hear me?
Yes, go ahead, please.
Perfect. All right, 2 minutes. All right. Hi, my name is Vincent Chavez. I'm a 10-year pharmacy tech at CVS. I'm coming on line item number 11, standard of care. Adding additional pharmacists and pharmaceutic duties, such as what is being proposed, is giving us the impression of putting the horse before the money cart. Community pharmacies, specifically CVS, are overwhelmed and understaffed. This past year of closures has only created more higher volume pharmacies, whereas low volume standalone stores have been consolidated, and there are no more low volume stores to actually help the patients more intimately one-on-one. This will only get worse with the uncertain future of Rite Aid and Walgreens in California, at least. Speaking on behalf of the bargaining pharmacists, what is being proposed here, they view it as dangerous and not feasible. It would have to be a dedicated team during the time this service will be offered. We are overwhelmed and micromanaged with current policies of needing upper management's approval for staffing hour changes and how we're going to pay back those hours. The company's representatives, Tom Guz and Amy Devine, had no interest in raising guaranteed hours for technicians or even their full-time pharmacists. Furthermore, CVS representatives also declined vehemently dedicated time to do any required module training that's required by the board, the state, the FDA, away from workflow. And adding more modules, more training is just short-sighted and counterproductive and will not be handled appropriately. If the board were ever to come to local 324 area, we can provide more face-to-face testimony of pharmacists with honest discussions, as long as there's no retaliations from the employer. Last comment, line number 9, delivery. Our only issue is in terms of delivering medication with these vendors or Ubers, such as we do
10
right
seconds.
now, is not delivering medications that need to be refrigerated when the temperature gets too hot outside. Thank you for your time.
Thank you for the comments.
Next, we've sent a request to Richard Dang. Hold on just a moment.
Hi, Richard Dang, commenting as an individual. I sent a letter to Debbie yesterday that did not get included in the board packet, unfortunately, due to timeline. Hopefully that can still be provided to you, but I'll touch upon the main points that I made in the letter. I appreciate all the comments made by the public and the board. I do want to emphasize that workplace conditions and standard of care are not mutually exclusive items, but are in fact compatible. To refresh everyone's memory, a common definition of standard of care is the benchmark that determines whether professional obligations to patients have been met, and that the level of care, skill, and treatment, which in light of all relevant surrounding circumstances, is recognized as acceptable and appropriate by reasonably prudent similar healthcare providers. This includes not only education, training, and competency, but also location, resources, and staffing support. The concerns about compensation and workload that have been raised are not about standard of care. They are about separate corporate business practices of the licensed pharmacists that can also be addressed in tandem in this process. Workload at a high volume store can be addressed through pharmacy to tech ratio. Standard of care enhances and reinforces the autonomy of the individual provider to make clinical decisions. And in fact, the sole discretion of the provider is exactly the definition of standard of care. So additionally, standard of care is permission to do something and not a mandate or a requirement. If we look to the other states that have implemented standard of care, such as Idaho, you will see that they have had no negative impacts reported, and there are many papers that have been published along with that, 2 of which I included in my letter sent yesterday. The board can move forward, and I encourage the board to move forward to support standard of care, but also to ensure that your proposed statutory language for the enforcement models are strong. In this process, the Board of Pharmacy can define what enforcement models are included for the comparable standard, which can
10
include
seconds.
resources and locations. I did have also the additional comments about pharmacy technicians giving immunizations and payment for non-pharmacy locations, but I'll save that for a separate time. Thank you.
Thank you for the comments, Dr. Ding.
All right. I may have just misclicked. Christopher, you're next. Christopher Adkins.
Hello?
Yes, go ahead, please.
Oh, sorry. Okay, yeah. Sorry, this is Christopher Adkins. I am a community pharmacist in Los Angeles, and I did have a long prepared statement to talk about standard of care, but I think that horse has been beaten far beyond death. So I'm going to shorten it a little bit and just say that in general, I think the wording in the standard of care model that has been put forward is very good to give pharmacists the autonomy that they need. And as a retail pharmacist, I think that I can share in what everyone else practicing in the retail setting has said, that they're worried about this will possibly expand what we're forced to do in the pharmacy. And I hope that the wording is strong enough that that will not be the case. And I think that's most people's concern, is that it is not. And it is still my concern. Maybe I'm a little scarred from being in the retail setting for so long and it having happened so much regardless of the new laws that have been put into place that have kind of curbed some of the non-licensed individuals and entities kind of taking over the pharmacist license in order to put profits over patient health and safety. So hopefully the wording is strong enough, and I think that's most people's concern here. And I just wanted to address that separately from just saying that I support or don't support any of the wording put forward. And also, I just wanted to say that to really expand the scope of practice, we must address the corporate pressures that are undermining the ability of many pharmacists to provide the care that patients deserve and that we can provide as experts. And I also wanted to touch a little bit on the PBM bill that failed, unfortunately. I think that does need to go back through and maybe focus more on the pharmacies just losing money in particular, because sometimes we're losing $10, $20, $100, $500 on a single
10
medication. And
seconds.
that's no way to do business, especially when an insurance company is telling a patient that their medication is covered and it's not. It's being covered by the pharmacy, which is not true. Thank you.
Thank you for the comments.
Next, we're hearing from Lanny Dong.
Hi there, can you hear me?
Yes, go ahead, please.
Hi, my name is Lonnie Dong. I am a pharmacist and commenting as an individual. I've done some volunteer work with Pizza's Not Working with Dr. Bled Tanaway. And I've been in AmCare for over 12 years. And so I absolutely support this, going towards the standard of care model. I echo the concerns of many that have spoken before me, and especially Board Member Crowley's comments that succinctly kind of presented the challenges that we're seeing in community pharmacy. The groups like Pizza Is Not Working exist because the fear of retaliation still exists. And we're still hearing from a lot of folks in community pharmacy that the issues have not abated, and I don't know where or how it can be addressed. I do appreciate that, AB 1286 does have some protections and that the autonomy piece is going to be the crux of it. But if we're asking pharmacists to, voice when they're, not sufficiently trained to provide a service, I mean, these pharmacists, the the fear of retaliation is so great that these pharmacists can't even, you know, advocate for themselves to go take a bio break. So that's not speaking to the confidence level of these pharmacists, because we're talking about hundreds of folks here. This speaks to the hostile environment that they work in. And so I really just want to make sure that we're doing everything
10
we can to
seconds.
protect this, you know, our colleagues that are in community pharmacy, because we are already seeing a lot of med errors and patient safety issues.
Time.
Thank you for the comments.
Next, we're going to hear from Paige Talley. All right, we're going to try this again.
With the California Council for the Advancement of Pharmacy, and I'm only going to speak to the pharmacy to pharmacist to pharmacy technician ratio. I know that you sent out a survey to pharmacies, and you said you had 4,510 pharmacists responded. But you also said that, and one of my long-term care pharmacies did receive this, and not all of the pharmacy owners are pharmacists. This one in particular is a pharmacy technician, and they service skilled nursing facilities, and I don't know if you're calling that inpatient or outpatient. And I know I'm not supposed to ask a question, but that's vital to this. So if it's they're people in skilled nursing facilities and ICFs are considered residents, and because it's supposed to be a home-like environment, but it's not, and I wouldn't want to be in one of those. But that's a side point. At any rate, I think that your attachment or your draft only addresses the community pharmacies. Now, if long-term care is considered a community pharmacy, I'm okay with the 2-to-1 ratio, but we would like more in long-term
10
care.
seconds.
Okay, but I guess I'll write a letter to you just to get some clarification, or Ann, I'll call you.
Time.
Thanks for the comments.
Next, we're going to hear from Parth Parikh. Hold on just a moment.
Hello, my name is Parth. I am a pharmacist provider in Los Angeles area. I am speaking in favor of standard of care. I just wanted to acknowledge some of the comments made by a lot of the commenters about how poorly for-profit chains are managing services when it comes to staffing and safety of patients. So I do acknowledge that. I also acknowledge that for-profit chains also have quota system, which also is making it very difficult for patient care. However, it seems like that is more of a business problem. It's a choice or decision problem rather than a problem that exists everywhere. So I would like to propose some solutions. If that is a serious concern, maybe having extra requirements for chain pharmacies to meet in terms of staffing, in terms of compliance, in terms of anything that we can bring safety to patient. I think that could be a potential solution rather than halting the entire idea of implementing standard of care. Another solution is just hiring more. Anytime you expand your business, you have to have people to operate that business. So I don't think it's relevant to even check and ask anybody that if you have enough staffing, because nobody will, since we're not really having that part of the business. And the last part is if push come to shove, maybe even excluding high frequency, high density chains from these advanced practices. Maybe they may not be ready, and maybe having some time to kind of come up with a way where they can also meet. But I just wanted to bring that to attention, not to really stop the entire process just
10
because
seconds.
of the safety concern. Thank you very much.
Thank you for the comments.
Next, we have Lindsay Gulahorn, excuse me. We're sending you a request to unmute your microphone.
And this is Lindsay Goldhorn with the California Community Pharmacy Coalition. Definitely appreciate the board's work on the Sunset Report and the time that went into it. Given the breadth of the document, which is over 100 pages, we are still reviewing it and compiling our feedback. Understand no changes are being made to the proposals today, but hope that there is time in the future, perhaps at the next meeting, to provide comment, or if not, at least to provide written comment, which we will plan to do. But do want to express that we support many of the ideas and proposals in the report. Just a couple brief things we want to note. With respect to allowing pharmacy technicians to administer more than COVID and flu vaccines, we would request that you consider also allowing them to offer and promote vaccines. Pharmacists, of course, would still do the clinical review for appropriateness and the consultations, but allowing this would expand access for patients. Vaccines like flu and COVID are considered universal recommendations, so letting patients know about them and encouraging them to receive them will help improve immunization rates. Also want to raise that with respect to expanded technician practice. 10 states allow technicians to perform final verification. So yes, it's true that pharmacists often don't have sufficient time to perform the expanded duties in attachment 10 because they don't allow techs to verify. Allowing technicians to verify would help solve this. Overall, though, appreciate, again, the work that went into this document and look forward to engaging in the legislative process. Thanks for the opportunity to comment.
Thank you for the comments, Lindsay.
Next, we have Susan Bonilla.
Thank you very much for CPHA. I would like to speak on a couple of the issues. First, I want to thank President O for his thoughtful leadership on all of these important issues, and thank you to the entire board and the staff. This has been a really heavy lift, and I just want to appreciate your leadership. First, on pharmacy deserts, item number 7, CPHA is concerned about the increasing number of pharmacy deserts in California in both rural and urban areas of the state due to the closures of pharmacies. We have seen that payer practices are increasingly impacting patient access and ultimately patient care. One of the most pernicious causes for closures is the unchecked practice of patient steering that we have seen happening, particularly by 3 large PBMs. And this steering is sometimes carried out very overtly with sending letters and saying you must go to this particular pharmacy or you must do mail order. But there's other hidden methods of steering, such as under reimbursements for medications. And this results in many pharmacies being unable to carry the full range of patient medications, and therefore by these patients are diverted in another manner and steered in another manner. We feel that prohibiting payer practices that negatively impact patients would be a very helpful measure in reducing pharmacy deserts. Just also very quickly on standard of care, of course, we strongly support this. We also want to go on record as saying we know many of our members are suffering with some workplace issues that are negatively impacting them. We want to work collaboratively to address and improve staffing issues at large volume pharmacies. And we want to do that in a dedicated effort, separate from the historic move to standard of care as a regulatory model.
10 seconds.
Thank you. We believe that standard of care needs to happen, but we also want to reassure that we are ready to work on these other staffing issues. Thank you.
Time.
Thank you for the comment, Susan.
Next, we're going to hear from Crystal A. Forrest. Hold on just a moment. We're sending you a request to unmute your microphone.
It's Crystal Frost. I'm here on behalf of, you guys can hear me, right?
Yes, go ahead, please.
All right. My name is Crystal Frost. and I'm here on behalf of California patients who rely on Category 1 sterile compounds and compounded medications in general. And I represent nearly 8,000 patients, practitioners, and caregivers who have signed our petition to protect access to these medicines. We oppose the Board of Pharmacy's attempt to regulate IV hydration clinics, and we urge against raising this during the sunset review process. IV hydration clinics are already regulated by the Medical Board of California, which oversees the medical practices within these clinics. IV hydration clinics are not pharmacies, nor are they doing compounding, as Ms. Serpa stated earlier. These clinics rather administer medications compounded by pharmacies already regulated by your board or by the FDA, and it's not within your jurisdiction to regulate doctors' offices. Licensed medical providers operate these clinics, and the Medical Board of California oversees the medical aspects of their treatments. Expanding the Board of Pharmacy's reach into these clinical options constitutes unwarranted regulatory overreach, encroaching on areas managed by the medical board and creating confusion and additional obstacles for clinics and their patients. Most importantly, their patients. No IV hydration clinic or medical clinic requires redundant regulatory oversight, and such an action will only harm our most vulnerable patients. Regulatory burdens will inevitably increase the costs of these essential treatments that are already not covered by insurance, further limiting access for chronic illness communities and patients with unique needs. Many patients rely on IV treatments to receive nutrients and medications they can't absorb otherwise, including people like myself with Lyme disease, patients with Crohn's disease, IBD,
10 seconds.
ME/CFS, long COVID. I have a lot more to say. Attempting to regulate medical clinics' use of compounded products feels like a backdoor attempt to further restrict compounding pharmacy.
Thank you for the comments.
Next, we have Michael Murphy. Hold on just a moment. We're sending you a request.
I'm sorry, just David, I hate to do this in the middle of comments, but I'm being told some of my members really need to use some bathroom breaks. So after this comment, we're gonna take a little bit of an awkward break in the middle of the line. So please keep your hands raised. We'll come right back. So after this comment, we're gonna take a quick 15-minute break, so members can at least have a slice of pizza and go to the bathroom. So back to you. Thank you.
All right. Thank you very much, President O. We're ready for you, Michael.
Thank you. Michael Murphy from the American Pharmacists Association. Overall, APHA is supportive of the standard of care language. The transition to a standard of care regulatory approach is aligned with how other healthcare professionals are governed and will allow for a greater alignment of the role of the pharmacist with their education and training. This will positively impact patients and the healthcare system as substantial published literature clearly documents the proven and significant improvement in patient outcomes and reduction in healthcare expenditures when pharmacists are optimally leveraged as members of the healthcare team. Thank you for the opportunity to provide these brief supportive comments.
Thank you for the comments. All right, we're gonna take a quick 15-minute break, and we'll come back. Please keep your hands raised, and we'll come back at 4:15. Okay, welcome back. Got to take a quick roll call. I appreciate everyone's patience, and we are taking a quick roll call. Jesse?
Here, can you hear me?
Thank you, Jesse. Renee?
Here.
Thank you, Jeff.
Here.
Thank you, KK.
Yep.
Thank you, Jay.
Here.
Thank you, Satinder.
Here.
Thank you, Maria.
Here.
Thank you, Maria. Nicole.
Here.
Thank you. And I'm here. We are back to you, David, for public comments. I appreciate everyone's patience.
All right. Next, we're going to hear from Kevin Komodo. Want to remind everyone that if you want to make a comment, raise that hand by tapping the hand button. Dial-in users, dial *3 to raise your hand. Kevin, we're sending you a request to unmute your microphone. All right, Kevin, I see you're unmuted, but I haven't heard from you yet. Are you with us? All right, hang on just a moment. Stay right there, Kevin. I'm going to put some instructions on the screen to see if we can fix your audio quickly. Bear with me just a moment.
Testing. 1, 2, 3.
Ah, there you are. Go ahead.
Okay, very good. Thank you very much. My name is Kevin Komodo. I'm speaking on behalf of myself as a community pharmacist representing a rural area. I really want to speak in support of the Board of Pharmacy and the standard of care, which is being discussed and implementation through the Sunset Review process. One of the things I would really like to bring out is that from the standpoint of the verbiage, I really like what the board is coming up with. There's been some concerns about labor and about staffing ratios, and I do believe that those are very important issues to bring up. I would also like to state, though, that I believe that the addressing of standard care should be addressed separately from that particular issue. Both are very, very important, but I do believe that standard of care should be addressed by itself. There's also the second issue that I wanted to address was with regards, there was a statement which was stating that, the primary motive for implementation of some of these programs within a independently owned business might be financial gain. I will tell you that most of the applications that we see in our area have absolutely no financial component tied to them. When I'm looking at our community, we come from an under-resourced area in which there's a lot of patients that do not have access to specialists. They do not have access to intermediary care providers. And what we find is that a lot of times pharmacists is the only thing standing between them and readmissions or possible medication misadventures. Very simple examples include when a patient receives their insulins and they do not receive the appropriate orders for the devices that are needed to deliver them. Also for patients being discharged from the hospital, they're missing orders which they've been on to continue life. And I just wanted to let you know that standard of care can be implemented and pharmacists are ready to engage in it to help mitigate some of these care gaps.
Thank you for the comments.
Next, we're going to hear from John Gray. John, you may need to dial *6 when prompted to unmute.
Thanks very much. Good afternoon. This is John Gray, registered pharmacist with Kaiser Permanente. First, want to thank the board for reviewing and addressing many of the suggested items that we provided in a letter earlier this year, including digitization of records, validity of prescriptions, and expanded pharmacy technician duties. There are a couple areas I want to flag for you to consider where it might benefit from a little bit more workshopping. First is attachment 8, 4067.1D. It appears that based on the fact that 4067.1A says, except as provided below, that the intent is to remove the reporting requirement for telehealth platforms used by health plans. If that is the case, it feels like there might be some words missing from 4067.1D to make that clear what you're trying to do. And then in attachment 9 for the white bagging, the way that we read, and I'm glad board member Thibault brought up the issue of pharmacies servicing clinics, because the way that we read the draft statutory language, it seems as though these requirements could apply to a pharmacy and a patient care site that are located in the same facility under the same common ownership or control. For example, an infusion center and the pharmacy that services it could be located in the same building under the same ownership or control, but because the drug is being delivered from the pharmacy to the infusion center, it looks like this requirement, this statute might apply. We think that could be fixed relatively easily by amending A to say delivery to a patient care site at a facility not under common ownership or control for administration, yada, yada, yada. So those are the two very specific items we wanted to comment on. Again, thanks for taking our comments on other areas, and thanks for all the great work on this report.
Thank you for the comments, Dr. Gray.
Next, we're going to hear from Daniel Robinson. Hold on, Daniel. We're sending you a request to unmute your microphone.
Dan Robinson, representing myself. I'm sympathetic to the staffing and workload issues, but I want to point out that California nursing staff ratios were implemented through AB 394 in 1999. After 20 years, California remains the only state that's placed staffing ratios into law. and there are mixed views regarding the outcome. Some say that the satisfaction is improved, but there's no studies to compare pre and post satisfaction scores. There's also no hard evidence that patient safety was improved. The standard of care regulatory model does not add to anyone's workload. Pharmacists should not perform any activity that they're not qualified or resourced to provide. Furthermore, the California Department of Public Health is the agency that sets fines for violation of nursing staff ratio, not the Board of Nursing. And then I want to refer to section 4052A10. I think it's important to point out that the statement, furnish FDA approved or authorized medications as part of preventative healthcare services that do not require a diagnosis. I think you need to add, except for diagnosis related to self-care. There's growing availability of home self-testing procedures that may prompt a patient to seek pharmacy services. SB 524, test to treat legislation, has already been introduced, which allows treatment allowing certain positive tests. Patients will increasingly come to the pharmacy with a diagnosis based on self-testing. So thank you very much for allowing the comment, and thank you to the board for your amazing work on the standard of care language.
Thank you for the comments.
Next, we're going to hear from Amy Homan. Hold on, Amy. We're sending you a request to unmute your microphone.
Can you hear me okay?
Yes, go ahead, please.
Okay, great. So my name is Amy Homan, and I'm a resident pharmacist at Loma Linda University. And I just wanted to express my strong support for the standard of care model for pharmacists in the state of California, because I want to be able to provide the most up-to-date patient care through current evidence and practice guidelines to the people that I serve, instead of waiting for legislation to keep up with clinical knowledge. The standard of care model pushes our profession into the future through this model, and pharmacists can serve our patients better by mitigating care gaps and addressing health disparities in the state. So I just wanted to thank you for everyone's time and all your hard work on addressing standard of care model and considering it in the state of California. Thank you for your time.
Thank you for the comments.
Next, we're going to hear from Gary. Hold on just a moment. We're sending you a request to unmute your microphone.
Hello.
Hello. Go ahead,
Okay.
please.
Thank you. Gary Bazink, Board Chairman, California Society of Health System Pharmacists. I have worked as a health system pharmacist for 39 plus years, and I strongly support instituting the standard of care enforcement hybrid model, emphasis hybrid, for pharmacy practice in California. Pharmacists reach further into California's healthcare deserts and can enhance the delivery of quality healthcare into those under-resourced communities, which is a big plus for patients. I also want to applaud the board's report to the legislator that stated that reimbursement is an inseparable component of standard of care. Additionally, I submit that artificial intelligence is already in use to do billing and may be useful in moving work out of the independent and small chain pharmacies to make way for the provision of clinical services by those who are comfortable doing so. I urge the board to strongly advise our elected officials to make standard of care happen in California. Thanks very much.
Thank you for the comments.
Next, we're going to hear from Daniel Kudo. Hold on just a moment. We're sending you a request to unmute your microphone.
Can you hear me?
Yes, go ahead, please.
All right, thank you. I'm Dan Kudo, and I'm a member of the public. I'd like to thank the Board of Pharmacy for their hard work on all of these issues. I've been a practicing pharmacist for 50 years, and I sympathize with the workload challenges of our community pharmacists. and the challenges they face. Yet I speak in support of the standard of care hybrid model of the Board of Pharmacy. Physician shortage is widening, and pharmacists are critical to patient access to quality care. Standard of care is aligned with other healthcare professionals. This is a unique opportunity for pharmacists to provide quality care to the patients they serve. Thank you.
Thank you for the comments.
Next, we're going to hear from Stephen Gray.
Thank you. Thank you very much. I support standard of care. And in fact, standard of care has been carefully used for over 30 years by some California pharmacists, those who are practicing under collaborative practice agreements. For those non-pharmacists on the board and those that are new, it would be very important to make sure you understand that thousands of pharmacists for over 30 years have been taking care of patients to the standard of care that is needed for high-risk patients and patients on high-risk drugs. Taking that burden off physicians, off nurse practitioners, and providing a higher standard of care. I also want to point out, as Dr. Richard Dang said, that standard of care is not a requirement under this proposal. Pharmacists that are not in a setting that is capable of it, it should not be attempting standard of care for various reasons. In the long run, that will sort itself out, but I understand we're going to go through a period of stress for this. I'd also like to point out in particular on item number 18, attachment 17, it is very important as you change the Business and Professions Code sections that you make sure that you change the Health and Safety Code sections where the Business Code sections are referenced. That wasn't done in the past and it's caused some problems. So be sure to go throughout the Health and Safety Code sections that relate to the provision of drug care and make sure that those are changed, please. Thank you very much. I look forward to helping with the legislation as it goes through the process. Thank you.
Thank you for the comments, Dr. Gray.
Next, we're going to hear from John Teague. Hold on just a moment. We're sending you a request to unmute your microphone. All right, we're going to try again on John Teague.
Sorry, I'm not. Can you hear me? I'm headed
Yes,
to
go
my
ahead.
car. I've been waiting for a while, so I'm not sure if this
Understood.
is gonna work out.
Go ahead.
Let's see. I'm having some technical difficulties. I don't know if you can hear me.
We can hear you just fine. Can you hear me?
Oh, okay. Okay, you can hear me. Sure, I'll try and make this brief. So good afternoon. My name is John Teague. I sent a letter yesterday, but I'm not sure if it made it into the packet. I'm a licensed pharmacist in Imperial County. I'm the director of pharmacy at Pioneers Memorial Healthcare District and owner of Desert Pharmacy, an independent community pharmacy. Sorry, I've been walking. So thank you for the opportunity to speak in support of standard of care. Our current rule-based regulations can limit our ability to adapt to new practices. Number one, standard of care would enhance flexibility, allowing pharmacists to use professional judgment. Number two, it'll improve outcomes, focus on patient outcomes other than rigid processes. Number three, encourage innovation. And number four, increase access to care. For instance, it would enable pharmacists to more timely sorry, I'm just having issues because I was running to my car because I got to get home. But more timely access to care to consumers, especially in underserved areas like the one I live in. For example, during COVID-19 pandemic, our pharmacy team at the hospital worked hard on COVID vaccines, but we needed board interventions just to be able to administer them. Number five, align with best practices, following successful models of other healthcare professionals and professions in states like Idaho and Washington, as well as recommendations from NABP. So what I wanted to end with was, despite these challenges, we cannot be afraid. Just as the characters in Disney's animated movie, The Croods, they learn to embrace new ways of living. We too must embrace change to improve our profession. Therefore, I urge the board to consider supporting
10
the
seconds.
standard of care. Thank you.
Thank you for the comment.
Next, we have Robin Corelli. Hold on just a moment. We're sending you a request to unmute your microphone. All right, we're going to try again on Robin Corelli. All right, Robin, we're going to pass you by. We're going to go for Maria Lopez, and we'll circle back to you in a minute. Maria, we've sent you a request to unmute your microphone.
Maria Lopez, Public Health Community Pharmacy owner. I want to thank the board for working to make a safer and healthier California. When California pharmacists practice at the standard of care, they're practicing best practice guidelines in line with other healthcare providers. The practice of pharmacy at anything less is substandard. As a Latina, Spanish-speaking pharmacist who serves underserved communities, which are uninsured and underinsured, I am particularly concerned about the 39% of Hispanic Latino Californians who make up a disproportionate share of health inequities without access to healthcare providers and, like their Latin American counterparts, often seek healthcare services at their local pharmacy. I do not want California pharmacists who are recognized healthcare providers practicing at a substandard level, because this means we widen the gap in already existing health inequities. There's been much discussion about the business store model, as others have noted. It is a separate topic. Importantly, standard of care guidelines are based on research and best practices. National healthcare experts create these guidelines, not business persons, not labor, not union groups. And it would be inappropriate for them to create these guidelines. These best practice guidelines are nonpartisan and are made in the best interest of patients. I implore on the board to make decisions based on best practice guidelines for pharmacist healthcare providers. Finally, as a public health consultant, I want to note our federal partners at the CDC, HHS, and CMS call to states to decrease barriers so that pharmacists can increase timely access to medication. Thank you for your time.
Thank you for the comments.
All right, next, Robin, we're going to try you again. I saw that you were able to unmute eventually. Let's try you again.
Can you hear me now?
Yes, go ahead, please.
Okay, very good. Sorry about that. My name is Robin Corelli. I'm a licensed pharmacist and I'm a faculty member from the UCSF School of Pharmacy. I speak as an individual in strong support of a standard of care oversight model for pharmacists in California. As been mentioned by others, and of course the previous speaker, I would like to echo the comments from Dr. Dang and Robinson that the standard of care model provides pharmacists with the authority to fully utilize their expertise and training, and it is not a mandate and should not be confused with the working conditions in pharmacies, that those are separate issues. This is a model that will support pharmacists to provide essential patient care services, especially in underserved communities, which we know can reduce health disparities. As an example, I'm a certified tobacco treatment specialist, and I'm working currently with pharmacies in the Community Pharmacy Enhanced Services Network, many of you are familiar with CPESN, to improve the treatment of tobacco use and dependence in rural communities. The standard of care model would greatly assist these types of efforts because pharmacists would have the authority to prescribe the most effective medications that are not currently allowed by our NRT protocol, which is varenicline. So these are the types of initiatives, the types of essential patient care services that we can be providing that the standard of care model will allow. And I would implore the board that this is the golden opportunity for the pharmacy profession to step up, to function at the top of their license, and take care of our vulnerable citizens and patients in California. Thank you.
Thank you for the comments.
Next, we're going to hear from Stephen Gray. Hold on just a moment, Stephen. We're going to send you a request to unmute your microphone.
I think we went through Dr. Gray already.
Yes, you did.
accidentally.
I thank you very much.
Thank you.
All right. Next, we're going to hear from Prashant. Hold on just a moment. We're going to send you a request to unmute your microphone.
Prashant. I'm actually a licensed pharmacist. I'm a multi-state licensed pharmacist and pharmacy owner in a multi-state as well. And currently I reside in San Diego and work between San Diego and El Centro area. I wanted to, give my strong support to the standard of care and, how important it is to serve in a, rural community like El Centro area, where there's not enough providers, to provide, such care. I also wanted to add that many of the, members today who joined the team, they raised the concern about the staffing issues and all, and that there's a pharmacy desert coming, many chain pharmacy and many independent pharmacy closing. But I would say this will give an opportunity for all this, even the, the pharmacists who are going to be eventually going to be losing their job, and there are more pharmacists who's coming in the market, graduating every single year. And by utilizing, these more services, it's not only give the solution to all those pharmacists to eventually provide, the standard of care, eventually provide the, the good patient care, and not only that, but also keep their jobs or get their jobs, because after all, pharmacists is not just who just verify the prescription and fill the prescription. We have got 7 years of educations, multiple trainings, and hundreds of hours of practical training, and this model actually definitely supports to utilize our full potential as a pharmacist and to help the the patients and to get the best care out there. So that's all I wanted to tell for today. Thank you.
Thank you for the comments.
Next, we're going to hear from Evelyn. Hold on, Evelyn. We're sending you a request to unmute your microphone.
Hear me?
Yes, go ahead, please.
Okay. My name is Evelyn Elliott, and I'm speaking as myself. I've been a registered pharmacist for over 50 years and have worked in the hospital acute care setting all of that time. I'm speaking strongly as a support of the standards of care efforts being taken on by the board. This is going to go a long way in elevating the practice of pharmacy to be commensurate with their education and training and the ability to treat our patients. I've heard the comments for people, concerns about workload in the retail setting, and I know that the devil is in the details, but you'll work that out. But I just wanted to commend the board for taking this courageous step for our future. And even as an old pharmacist, I'm very happy to see this. I'm just very excited. Thank you.
Thank you for the comments.
Next, we have Lucas Evanson. Hold on, Lucas. We're sending you a request to unmute your microphone.
My name is Lucas Evanson, speaking on behalf of the California Medical Association. CMA requests that the board not incorporate the standard of care proposal in its sunset report. Many of the services incorporated in the board language go beyond what pharmacists can currently do. This is a bigger conversation that warrants additional deliberation that incorporation into an omnibus bill does not afford. In addition to needing to parse out the details on the alignment between included authority and education and training, as discussed in the report, there are considerations to be made about clinical independence from corporate when providing treatment. The board is pursuing other legislative changes to address use of AI in pharmacies over concerns that pharmacies have begun using AI to supplant their pharmacists' judgment, an example of corporate influence on the practice of pharmacy to patients' detriment. Given the board's priority on consumer safety, we believe that it's important to address this consideration and also argues against inclusion in the Sunset Report without further deliberation on the subject. Thank you for your consideration.
Thank you so much for your time.
And potentially last, we have Clint Hopkins. Hold on just a moment, Clint. We're sending you a request to unmute your microphone.
Members of the board, my name is Dr. Clint Hopkins. I own 2 independent community pharmacies and an LTC closed-door pharmacy in Sacramento and LA. My comments are related to the standard of care model. I am in strong support of advancing the standard of care model. A bad work environment needs to be addressed between the employee and the employer. As a recovering chain pharmacy employee, a current pharmacy owner who regularly has to tell patients I cannot help them with their medications due to the financial hardships that PBM contracts impose upon pharmacies, and a pharmacist who also has open positions for both pharmacists and technicians, I am sympathetic to the comments of those regarding staffing issues in our profession, particularly at chain pharmacies, which are notorious for squeezing profits at the expense of patient safety and a pharmacist's mental health. You are right, pizza is not working, but you can change your environment. The Board of Pharmacy should not conflate the movement to standard of care, which will allow pharmacists who choose to help their underserved communities with accessibility to healthcare with employment relation issues from bad actors in our profession. Standard of care practices can and should be implemented where pharmacists can effectively provide these services. At my 3 independent pharmacies, we staff appropriately for the services we provide, and our pharmacists are empowered to make decisions about what they can safely do in the course of their day. If we don't have the capacity to see a patient, we let them know and we offer them an appointment to come back later. Our pharmacists can say no if they don't have staffing to perform a clinical service and refer them to another provider, the same as any other provider who is at capacity in their clinic. My trained pharmacists are completely capable of ordering labs when a patient presents with symptoms of, for example, a bacterial STI, then reading those results and following algorithms set forth in our collaborative practice agreement by the CDC to treat those infections. Just yesterday, we treated a symptomatic patient and 4 partners via the Expedited Partner Therapy Act. A standard of care model would afford these services to millions of Californians who may otherwise go underserved. Californians should not have to wait for enhanced pharmacist care. Thank you.
Thank you for the comments.
And we have one more, Stephen Thompson. Hold on, Stephen. We're sending you a request to unmute your microphone.
My name is Steve Thompson. I'm the Director of Pharmacy at Torrance Memorial Medical Center and a past president of the California Society of Health System Pharmacists. Speaking on behalf of myself, I'll make this very quick and speak in favor of the standard of care hybrid model. As a pharmacist for over 47 years, this is a great opportunity for the practice of pharmacy in our community. I'm in agreement with Dr. Richard Stang, Dr. Gary Basink, and Dr. O's comments. And I'd also just like to say thank you, and I appreciate all the work that's been done on the Sunset Review Report. Thank you very much for the opportunity to speak.
Thank you for the comments.
And that indeed was our last comment on this topic.
Thank you, David. Thank you, everyone, for very, very important thoughts and all the time you spent. Just so that we're all on the same page, I am planning to go to closed session at 5:30. Any items that we are not able to touch today, we'll cover tomorrow, starting at 9 a.m., just so that everyone can expect. So we'll cover as much as we can until about 5:30 today and the open session, and then we're going to go to closed session at 5:30. All right, with the motion and second and all the public comment, we're going to have, I'm going to open up for members for your thoughts before we go for vote. I have few of my thoughts, but I'll open it up for Jesse. Go ahead.
Can you hear me?
It's a little delayed.
There we go. Okay. I have a few notes. I know this was a long public comment period. So thank you for everyone for sticking through this whole day's meeting. The first comment I wanted to mention was a comment about the window for change of PIC for non-residents licenses. I actually agree that a longer window may be appropriate for that because it's going to be more difficult for a non-resident pharmacy to find a PIC replacement, and I would be open to a change to 90 days for a change of PIC for non-resident licenses. I also agree with the discussion of having technician immunizations outside of a pharmacy, as long as there's a pharmacist supervising. If they're able to do it inside a pharmacy, it makes sense that it would be allowable outside of the pharmacy. And I think there would also need further discussion about the ratio requirement. Of course, in that instance, you wouldn't necessarily need a technician in workflow. Let's see what else I have. So I wanted to talk back. I think the last thing was just the standard of care. Of course, we've heard about this ad nauseum at this point, but standard of care is different from employer requirements, and I don't think it's necessarily a separate issue personally from staffing. I think that discussion needs to be happening simultaneously. I also want to emphasize that the med error reporting system is not up and rolling, and I think we would have a better perspective on patient safety if we actually did have med error reporting requirements up and running, and if we had that data, that way we could track the transition and see what the changes look like over time. So some of the things that I wanted to get feedback from other members on were some potential changes to kind of find a happy medium. So personally, I mean, I would be open to specific requirements for a chain setting, potentially having 2 pharmacists requirement there. Or mandating that the PIC be the person who's able to determine not only the staffing hours, but also the actual staffing and control over the scheduling system for these type of services. And I'll leave my comments at that.
Thank you, Jesse. Members? I think everyone's just exhausted. Go ahead, Fatinder.
Just echo what turned off. Oh, sorry. I'll echo what Jesse had mentioned. Definitely for non-residents pharmacies, considering that we have separate exam, as Mark pointed out, and some of the others, either the longer window or maybe require them to do at least do the PIC training or something that we offer in California. That's another option. So they're familiar with our rules and regulations, assessment forms, and so on. The other thing that I definitely think that I was surprised when I originally led the regulation, that somehow technicians were left out from be able to supervise in offsite situations, because today it's so common that we provide immunizations and we can't use technicians outside of, and I would like to have it actually expand so our technicians can provide all immunization, just not the flu and COVID. So that's the other. And I agree with many of the speakers that said that the labor part and the standard of care are too independent, and we shouldn't stop from going forward. Instead, we should work continuously to make sure that it is closely monitored and addressed as issues come up, as I think many of the speakers echoed.
Thank you for the comments, Tinder. Any other member comments before I make some comment? Go ahead, Jesse.
Sorry, the one last thing I forgot to add to was just that I would also recommend that we actually wait for the results of the updated workforce survey. We recognize that there's a need for it. And so it makes sense that we have more data before we move forward to something that's going to dramatically change the way that pharmacies operate in our state.
Thank you for the comments, Jesse. Okay, so we heard a lot. I just want to cover a few things. I think we should try to address AB 317 in a pharmacy, not just limited to the pharmacy, despite some payer comments that it's not as restricted, but I think we still should try to tackle that. We should probably tackle some patient searing and harmful consequences of patient searing. Also, I don't know if this is possible, but we should look at cost reimbursement. I think technician immunizing beyond just the flu and COVID should be considered, as well as outside of pharmacy to assist pharmacists I do think that there's an opportunity here to strengthen our very advanced reforms we put forth in AB 1286 and maybe make it a little bit stronger as concerns are raised, totally understandable concerns. So I think those are all some things we can look at. I'm sure there's a very happy medium, but this is too big of an issue. I'm sure we'll need to hopefully come together. Not everybody's gonna be all happy, but I think that this proposal is still a very, very significant proposal that is advancing patient care, and I hope that we can move forward. Members, I'm gonna open up for one comment. I know that there's so much discussion, so before we go for vote. Go ahead, Maria.
I'm just hoping that you could clarify what you probably said in your original statement, opening statement, about what is a sunset review report and the work that's going to still continue in upcoming committee meetings and board meetings on all of these issues. This is not just a blanket approval of 20-something items. So
Thank you, Maria. That's I appreciate that. I hope if that's how it came across, that was not the intention, but I'm actually going to punt this to Anne because we've worked together on these issues. And I think in terms of process, she might be, again, a good reminder for everyone. So Anne, go ahead.
So what I would say is this is one of the elements of the board's legislative report. And I believe the intent is at the December meeting to review the rest of the report for approval. The entire report is due January 6th. In terms of what gets moved forward in a legislative proposal, that's not necessarily a decision of this body, right? That's really a decision of the oversight committees and the entire legislative process. So there is opportunity for continued public engagement throughout the legislative process. This is, the board's report, but, these are statutory proposals. The board's sunset oversight review is done by the legislature. So there's many opportunities to continue to engage in the legislative process.
And I just want to add that I know that 22 items, it sounds like, and then 2 minutes. I know it sounds like, oh my God, we're just rushing things. That it's really not the case, as a lot of these things we've discussed for years. I just want to put it out there that we've talked about all these things, non-resident PICs, standard of care, technicians, tech training, literally everything in this report, almost at every point of the way that we've talked about it at the committee level and at the full board level. So I just wanted to make sure that's out there before I call for a vote. And before I solicit one last comment.
I have a question just in regards to the vote itself. So is the vote, the language is presented, or is it also including some of the discussion? I guess that's what we need to be clear about.
It's absolutely including the discussion, and there will be a lot of opportunity for finalizing it. And ultimately, this is not our decision, right? So that's the key. This is so much bigger than all of us. So we're going to try to put forth a concept, but ultimately it's the legislature's decision. Good to go? All right. Okay. I'm going to just vote first on this one because it's exciting. So I'm going to vote yes, then go to Jesse.
No.
Thanks, Jesse. Renee?
Yes.
Thanks, Renee. Jeff?
Yes.
Thank you, Jeff. KK?
Yes.
Thanks, KKJ.
Yes.
Thank you, Jay. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. Nicole?
Yes.
Thank you, Nicole. And the motion passes. Thank you, everyone. I am sure we will be hearing more about this in future meetings as well as next year. Next, agenda item 10, we're going to push forward, is discussion and consideration on the board's strategic plan. As you may recall, the board's strategic planning session occurred as part of the board's September 2021 meeting. Following adoption of the new plan, on an annual basis, the board reviews its strategic plan to confirm the established strategic objectives for each committee remain appropriate or if changes should be considered. This annual review also serves as an opportunity for the board to evaluate progress in the respective areas. You may recall, the board was originally scheduled to discuss the strategic plan during the July 31st or August 1st board meeting, but postponed discussion given some time constraints. I will ask the chairs from the respective committees to provide the board with an update on its discussion. I note from the meeting materials that the Enforcement and Compounding Committee is offering a recommendation to change their respective objectives. From a process standpoint, as only one committee is offering changes, we'll consider the reports for each of the committees and we'll consider the recommendation from the Enforcement and Compounding Committee at the end before requesting public comment, which will be taken at the end of the board's full discussion. As a chair of the Licensing Committee, I'm pleased to report the status of the various objectives established for our committee. During our meeting, we did not have an opportunity to review. You'll note that the committee has made steady progress on the strategic objectives. As reflected in the meeting materials, the committee continues activities in support of a number of the strategic objectives, and I believe work will be completed in the coming year for some objectives, including 1.3 and 1.4. And I look forward to updates on several objectives related to business modernization activities. Knock on wood. I believe the objectives remain appropriate. I would like to first open it up to any of my fellow committee members for comments. Seeing none, do any other members have any questions or comments on licensing strategic objectives? Seeing none, I am going to pass it off to Maria Serpa, Chairperson of the Enforcement and Compounding Committee. Maria?
Thank you, President O. On behalf of the Enforcement and Compounding Committee, I'm pleased to provide the board with an overview of the strategic objectives for the Enforcement and Compounding Committee. As indicated in the meeting materials, the committee has 10 strategic objectives. I'm really proud of what the committee has accomplished towards its strategic objectives and looking forward towards our continued efforts, including our activities related to reducing medication errors, which is core to our consumer protection mandate. I'd like to acknowledge the progress staff have made to meet the strategic objective 2.3. I believe we are making great strides to reach the 4-year benchmark. Currently, 79.7% of pharmacies have been inspected within the 4-year period. This is an increase from 37.7% just 3 years ago. I also want to highlight that only 0.3% of licensed pharmacies have never been inspected. As I shared during the committee meeting, I assume those facilities will be prioritized in the coming year. I look forward to our continued pursuit of the strategic objective and offer my sincere thanks to our inspectors. I'd also would like to highlight that while our committee's work is completed on strategic goal 2.5, specifically related to the consideration of further use of standard of care enforcement model with a submission of the legislative report. Work in this general area continues through the licensing committee. As you may recall, the licensing committee is considering statutory provisions related to the more robust standard of care practice model for pharmacists. We heard a lot about that during the sunset discussion. As we continue our work related to strategic objective 2.8, I believe it may be appropriate to focus some efforts on education of non-resident pharmacies. This would serve as a nice complement to the work being undertaken by the licensing committee related to the regulation of non-resident pharmacies. Our work related to strategic objective 2.10 resulted in the initiation of the formal rulemaking process to update the board's compounding regulations. I'm very proud of the work we have completed as a committee and truly appreciate the engagement we have received from all interested parties. You will note from the meeting materials, the committee is offering a recommendation to add a new strategic objective. Specifically, new objective would be 2.11. Enhance patient consultation compliance by evaluating barriers to consultation let me make sure I say this right. Enhance patient consultation compliance by enhancing evaluating barriers to consultation to provide patient education and reducing medication errors. It's my understanding that the board will be considering the committee's motion following the completion of all of our updates. Members, do you have any questions or comments regarding the committee's strategic objectives?
I just want to say that I really like the addition of the 2.11. I think that's an excellent objective, and I can't wait to hear what the committee comes up with.
Thank you. That concludes my update, so I turn the meeting back to you, President O. Thank you.
Thank you, Chair Serpa. Now we're going to Jesse for the Legislation and Regulation Committee. Jesse?
Thank you, President O. As indicated in the meeting materials, the Legislation and Regulation Committee has 6 strategic objectives. The meeting materials include updates to the respective objectives over the past year. These updates highlight the work of the board in our policymaking efforts to protect California consumers. While there are no specific updates to provider status, I do note that the passage of AB 317 provides for reimbursements under specified conditions, which is related in part to the policy goal of provider status. And we've had some discussion about that today as well. Members, do you have any comments on the committee's strategic objectives? Seeing none, turning it back over to you, President O.
Thank you, Jesse. And then next, Nicole will be providing the strategic objectives from the Communication and Public Education Committee. Nicole?
Sure, thank you. As the Vice Chairperson for the Communication and Public Education Committee, I am providing the update. As indicated in the meeting materials, the Communication and Public Education Committee has 8 strategic objectives. The meeting materials include updates on the objectives, highlighting our efforts over the past year. The committee reviewed the objectives and believed they remain appropriate. Members, do you have any comments on the committee's strategic objectives? Y'all are really small on my screen, so you'll have to just speak up. None? Okay, then I turn the meeting back to you, President O.
Thank you, Nicole. Okay, the last report is strategic objectives that fall under the purview of the Organizational Development Committee. The committee is comprised of the board president and vice president, who meet with the executive officer to discuss items under the purview of that committee. The meeting materials detail out the various strategic objectives, and status updates are provided. As noted in the meeting materials, several activities have been undertaken in support of the committee's strategic objectives. I would like to highlight some of the training completed by board staff under Objective 5.3, also Strategic Objective 5.4 related to business modernization activities. I'd also like to thank staff for their work to update information on the board's website as noted in activities related to Strategic Objective 5.6, and I think it looks great. Members, do you have any questions or comments on the strategic objectives for the Organizational Development Committee? Seeing none, and as I stated at the beginning of our discussion for this agenda item, the Enforcement and Compounding Committee is offering a recommendation, with the committee's recommendation serving as the motion. We'll now open the agenda item for public discussion, beginning with members of the public in San Diego. Don't have anyone in San Diego, so we will go to WebEx. David?
We are open for public comment on agenda item 10. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand. And for mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. Thank you. Okay, with a motion and oh, go ahead. Come on over. We have a public comment in San Diego.
Hello there again. Elle Sieber. I wanted to, as a patient advocate and public health consultant that does not in any way have expertise on pharmaceutical elements, I'm very confused by section 2.9, and I'm trying to understand why the Board of Pharmacy is able to assess IV hydration clinics that are not under its regulatory purview. That's very confusing and concerning to me as a citizen. Thank you.
Thank you for the comments. Since we were back in San Diego, I just want to make sure, any other comments in San Diego? Okay. And we're back to votes. Ready for vote? Jesse, how do you vote?
Yes.
Thank you, Jesse. Renee?
Yes.
Thank you, Renee. India? I'm sorry, India's not here. Jeff?
Yes.
Thank you, Jeff. KK?
Yes.
Thank you, KK. Jay?
Yes.
Thank you, Jay. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. Nicole?
Yes.
Thank you, Nicole. And I vote yes. The motion passes. All right, we're going to try to do one more thing if we can. We'll try. And if we don't finish, we'll just have to finish it up tomorrow. Agenda item 11, discussion and possible action related to proposed amendment to California Code of Regulation Title 16, Section 1709.1, related to designation of pharmacists in charge, including review of comments received during the 15-day comment period, initiated to address issue raised by the Office of Administrative Law. The next item for our consideration is the board proposed changes to California CCR section Title 16 section 1709.1 related to pharmacists in charge requirements. As a reminder, in January 2022, the board approved proposed regulation text to amend section 1709.1. The most recent comment period closed on November 1st. As such, supplemental meeting materials were posted and released on November 4th. We apologize for the delay, but it was unavoidable given the timing of the comment period. Received very few comments. I trust members had an opportunity to review the comments received and the staff recommended responses. I have reviewed the information and agree with the staff recommended responses. I note that the meeting materials and meeting slide have proposed motion language that could be used to adopt the regulation text. As I open for member discussion, I would also entertain a motion if you believe such action is appropriate. Members? We're agenda item 11.
I'm willing to make the motion.
Thank you, Maria. Any second?
You want me to read it?
Oh, sure. Go ahead.
Yeah.
Yes.
Move to ratify the modifications to regulatory text published during the second 15-day comment period from October 17th, 2024 through November 1st, 2024, and accept board staff recommended comment responses in, well, we had no discussion. Additionally, direct board staff to take all steps to complete the rulemaking process. That's the motion.
Thank you, Maria. Do we have second?
This is Renee. I'll second that.
Thank you, Renee. Appreciate that. With a motion and second, any other member comments? Seeing none, we're ready for public comment in San Diego. Seeing none, we're ready for WebEx.
We are open for public comment on agenda item 11 and the motion before us. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. Thank you. With a motion and second and public comment, we're ready for a vote. Jesse, how do you vote?
Yes.
Thank you, Jesse. Renee, how do you vote?
Yes.
Thank you, Renee. Jeff, how do you vote?
Yes.
Thank you, Jeff. KK, how do you vote?
Yes.
Thank you, KK. Jay, how do you vote?
Yes.
Thank you, Jay. Satinder, how do you vote?
Yes.
Thank you. Maria, how do you vote?
Yes.
Thank you, Maria. Nicole, how do you vote?
Yes.
Thank you, Nicole. And I vote yes. All right. Next agenda item is 12. This is discussion and possible action related to proposed amendment to California Code of Regulation Title 16, Section 1711, related to quality assurance programs, including comments received during the 45-day comment period. The next item for our consideration is the board's proposed changes to California Code of Regulation Title 16, Section 1711 related to quality assurance requirements. As a reminder, in January 2023, the board approved proposed regulation text to amend Section 1711 related to the board's quality assurance program. You may recall that as part of the board's medication error reduction and workforce committee, this ad hoc committee took a deep dive into the issue of medication errors. Through this work, one of the action items identified was the need to update the board's QA regs that have largely remained unchanged to almost 2 decades. The board's 45-day comment period closed on September 23rd, 2024. As noted in the meeting materials, the board received a number of comments. The meeting materials include several items, including the proposed regulation text as initially noticed, comments received during the public comment period, staff recommended responses, and recommended changes to the proposed text in response to the comments received. I note that the slide being displayed shows the changes being recommended in a very small font. Members, I trust everyone had an opportunity to review this information. I have reviewed this information, agree with the staff recommended response. I note that the meeting materials and meeting slide have proposed motion language that could be used to adopt the regulation text. As I open for member discussion, I would also enter to the motion if you believe such an action is appropriate. Now, if you all want to have further discussion on this, we can table this and bring this up tomorrow, but just wanted to get all of your, okay. Go ahead, Marie.
I have discussion.
Okay, it's probably best that we bring this for tomorrow in that case, I think for time's sake, right? Yeah,
Okay.
I think it's best interest for everybody. We've had a long day. So we'll just start this item, agenda item 12 tomorrow. And we'll start at 9 a.m. with agenda item 12 tomorrow. And so then the board will go to closed session in about 10 minutes. So we'll adjourn. The open session of the day is adjourned. Thank you everyone for attending, enduring through this long meeting, and thanks to all our members for your always amazing work. So we're gonna go to closed session at 5:25.